Hello, online folks. There are 2 people here in person and 4 of you online. So I'm going to give it a couple minutes and see what happens. I think we'll probably do the dryer, less discussion-y stuff tonight, since that'll be, because a couple folks did tell me that they were just going to watch like recorded whatever, and I'm like, that's fine. And so maybe the material that is less prone for discussion. Let's see. Yeah. 1, 2, 3, 4, 5, 6, 7. All right, we're up to 9 total. Cool. Okay, Handmaid's Tale. Or what? Like, to like. Yeah, like you just can't leave the state at all. You're just stuck there. For what? What if I live on the border and I want to go visit my neighbor?
They don't want to like go into a different state. They're like every pregnant woman's gonna want an abortion. What does that tell you?
There's a lot of really fascinating misinformation. Like there's been a few things, and there's always weird, fascinating misinformation. But there was one floating around the last week or so about a new California law that people believe allows them to legally like murder their newborn child. But the law actually says up to like 28 days or something. It makes no sense whatsoever. Because if you go read the text of the actual law, all it is protections for people that experience like miscarriage or stillborn or things like that to not have civil or criminal liability. And like, that's it. And the text of the law is very, very clear. But like someone somewhere started some like weird rumor. And I'm like, do you guys not just know how to read? And they're like citing parts of the law that are just completely like but you just spelled it out. You just copied and pasted what the legislation says. And you're still saying the opposite of what it actually says. It's strange. There's another one going around right now of like, now there's always these like weird like kidnapping horror stories. There's another one going around that if you get a dirty text that's to a wrong number, that it's some sort of like trafficking scheme, as opposed to just like a regular like phishing scam. Yeah. And and things like that. It's like my state phone gets spam texts from like ham sites all the time, because whoever had that number, his name was Omar, and I know that because I get texts that are like, "Hey, Omar." Yeah, it is like the stupidest thing, but I'm like, clearly this was just Omar misusing state resources to like go look at porn. Like, I don't care, whatever.
Yeah.
But like,
now it's your problem.
but there's like this level of paranoia that like there's child traffickers out like kidnapping like mediocre white kids in the suburbs, just plucking them off the street and tossing them into vans. And like, that's not how that works at all. Yeah.
That's the way. That's what I've just been saying.
Yeah.
Or it got passed. Either way, it got pretty far along that charged with felony.
Yeah.
So he probably tried to court case.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10.
Like it's already hard enough for that. Yeah.
So we are at 12 out of 16, and it's 6-0. Poor Monica. Monica, we were talking about this ridiculous legislation in Oklahoma. Somebody in person brought up that is no longer, they are putting certain rules around pregnant women leaving the state. Yeah, so what you delved into?
Oregon?
Yeah, it's a thing. All right, so I'm gonna get the sound back up there again because that seemed to work better. I'm guessing that the other 4 folks we're waiting for aren't going to be here since it is already 6:05, which is fine. Is it really just you 2?
We're your favorites.
That's fine. I feel like a jerk now. I should have just told everyone to do virtual. Okay.
Are there just 2 in person over there with you?
Yep.
Oh, that's so sweet.
No, I mean, it's late now. Everyone else is already logged on. And yeah, the material for today is pretty long. So there's no playing hooky today.
Yeah, we just go on Zoom and downstairs.
You're welcome to do whatever you want, honestly. Like you're adults. I don't. Is this gonna work or not? Hey, somebody say something. Hi, David. Are you feeling better? No, you have to say so verbally.
What are we supposed to say?
Hi. Speakers. Okay. Well, it doesn't want to work apparently. That's fine. So. Today's material, we're going to go over the case studies. And then I was telling the 2 people that are here. Today's material is kind of a hodgepodge of 2 different, now I feel like I'm ignoring you 2. I'm like talking to the computer here. So it's kind of a hodgepodge of 2 very different topics. And one of them with the Monday section ended up turning into a really long discussion. So I think we're going to save that piece for next week, since next week we're talking about ethics and, you know, all of those sorts of issues. And the material for that portion makes a lot more sense in the context of ethics discussions, and instead focus tonight, which we did not get to in the Monday morning section, on a semi-related but mostly not related topic around other mental disorders and medication-induced disorders, as opposed to all of the other various conditions or things that you might be seeing clients for, and all of the kind of various encounter codes and things like that there. I'm gonna give this whole sound thing one more try because it's really odd that it doesn't want to play out of the speaker. Why don't you? I don't understand. Is
Do you
it?
want the other 2 people in class to hear my chewing, or?
I cannot hear any, I can barely hear you at all.
Oh,
Let's try this. All right, try again. Now I hear nothing.
I'm really tempted. I'm really tempted to just chew by my microphone.
Don't do
But
that.
I
Don't
won't.
do that.
I won't do that. No, I won't do that.
All right,
That
we're
would
just
be
gonna use the
very weird.
computer. You guys want to like gather around, or are you comfy over there? You look pretty comfy. Sure,
Oh, like be there.
if you want to. You have like your stuff set up though.
What if I love
I really don't care. I just don't want you to think that I'm ignoring you. So just like throw something at me. Not only are there only 2 people, they're sitting completely opposite from me. This class is so glorious. Yeah, look at this. It's like all the way. Ahoy. It's okay. Anyway, so a couple of things.
I love how we only saw a table when you showed us the 2 people. We just saw a
Perfect.
table.
That's fine. That's fine. This is great. Whatever. I feel like we're all friends at this point because it's just been such an awkward term. Speaking of awkward things, so I'm waiting to hear back from Dr. Sweeney about some things regarding the final, because on Canvas, it says no time limit, but as we have learned previously, when it says there's no time limit, it means that there is actually a time limit. And so I need to find out what that is exactly before I tell all of you and fuck it up again. Number 2, there is going to be a small bonus assignment that I just decided I'm going to do because some people asked me. And if you already have an A and you send me a bonus assignment, I'm just going to delete it because I don't want to do extra work and you shouldn't do extra work either. But if you have a B or below, the bonus assignment is for next week's discussion, which is whether or not the question is whether or not Oregon is a duty to warn versus duty to protect state. in the context of things like mandatory reporting, so on and so forth. And just find me something that says which one it is and what your job would be in that context. Thinking about things like child abuse, elder abuse, all that sort of stuff. Duty to warn versus duty to protect. Which one your type of license will be in Oregon. And don't, shout out the answer right now. So let's talk about the case studies for this week. These were lots of discussion around these in the Monday section as well. Mr. Schneider. What's going on with Mr. Schneider, did people think? This is like more work for you two, because I'm just gonna sit here and stare at you guys until somebody says something. Yeah. Right, just take turns. Or anyone online, obviously. What diagnosis did you put for Mr. Schneider? I received a lot of different answers. And I think a lot of the different answers were because there's lots of information here, but there are only a few things that we actually know for sure. And then I think there was also some discrepancy in responses because it would depend on when you, the clinician, are diagnosing Mr. Schneider. So up here in this area.
So I can go, sorry. I did Alzheimer's disease, major neurocognitive disorder due to Alzheimer's disease. I had a couple other ideas, but I didn't know. I felt like I had a lot more questions before I did any other diagnoses.
Yeah, and that's the thing that's a little wonky here is we see lots and lots of evidence for Alzheimer's disease, right? We're seeing the issue with the enlarged ventricles. We are seeing the behavioral pieces. We are seeing the degeneration, the dementia, all of that. We are seeing, issues with sleep, issues with potential issues with alcohol use, lots of things. Within the context of Alzheimer's disease, all of those other than the alcohol use make sense. And there was some debate whether or not, without having an official diagnosis of Alzheimer's disease, if you would list that or not. And so the things that we know for sure are that you could either put a possible or probable major neurocognitive due to Alzheimer's disease, but you probably wouldn't also list the Alzheimer's disease because we don't do the technical diagnosis there. You would be getting that from the doctor or from the neurologist or that kind of thing. It's a really weird thin line, neurocognitive, we can 100% diagnose because we're basing it on cognition and behavior. So the neurocognitive disorder you can totally diagnose and you can say due to probable or due to possible Alzheimer's. And because we are not the medical person, we don't diagnose the Alzheimer's itself. So it's a really weird thing. And every single thing that's listed in here tells us what we know about Alzheimer's. And because it doesn't actually say he's been diagnosed with Alzheimer's, I would probably not put that there. The other one that I got pretty commonly was a delirium, which makes sense. If you are the person who is doing let's say you're the person who's assessing Mr. Schneider when he first comes in, you would diagnose him with a delirium when he comes in and he's disoriented, right? And then based on history, you would then also diagnose the neurocognitive disorder. So it really just depends on which point in time you are diagnosing him. And yeah. Oh, there's a little person. There's a little person. Let me find the little person. Are they gone now?
Oh my God, I totally thought, I was like, this is so not okay that she's saying this.
Did I get in trouble? What did I say? Oh no.
Wrong type of tiny person.
Oh my God.
I was like,
No, that's terrible.
Kathy, that's on you. Kathy, that's on you.
No, we are not. No.
I didn't read it at first. And I was like, what is she talking about?
That's amazing. I've been asked to speak at the graduation for the MSW program, and I asked my clinical students, because there's only 6 of them and I have them all year, and it's a very sort of intensive course, and there's site visits and all that stuff. So we know each other pretty well. And when I said that to the class, one of them just burst out laughing, like spit out her drink. And I'm like, why is that so funny to you? And she's like, I just want to see what's going to come out of your mouth. And I'm like, that's fair. All right. Any other questions about Mr. Schneider?
I wish you could be.
I don't know. I don't think we can. I think the board is weird, and I don't know. Like LCSWs can do clinical supervision, I think, for folks that are going for their LPC and for their LCSW, but I don't know for sure. And we're allowed to supervise folks at their field sites, but we're not allowed to, I don't know. There's all sorts of wonky, bureaucratic. Yeah. Any other questions about Mr. Schneider? Okay, cool. Beatrice. So this is another one where we would look at, point in time diagnosis versus historical diagnosis versus, when are we actually seeing Beatrice, and when are we diagnosing her?
I'll give it a shot. I put mild neurocognitive disorder due to another medical condition.
Okay.
And then I also put other specified trauma / stressor related disorder, because I think that could also be helpful to like treat for, because like that had to have been a traumatic experience. And so like maybe ruling that out, or like at least like acknowledging that like that was really intense.
Yeah. And that's something we should be looking at really with anybody that is dealing with these kinds of issues, because as a person loses their abilities, right, that can be very, very traumatic, especially if they're, found wandering around. So tell me why mild and not moderate and not major.
That's a good question. I don't really know, to be honest. It was kind of just a guess of like, it was like, it looks like according to the study or to the case that it's starting to like regress or resolve a little bit. And also needing to pay attention that like it could also pop back up again, and then like reevaluating it later.
Yeah.
What are your thoughts on that?
Well, the DSM doesn't give you a lot of good, we've talked about this before, where there are some diagnoses where it says if it's this many symptoms versus this many symptoms, that rates the severity. There are others that say how much it affects the person's life, that rates the severity. The DSM doesn't give you good guidance on mild versus major. And I think a lot of that is because it's very, very subjective, and a lot of it depends on the resources available to the person. And by that, I mean, we're looking at ADLs and IADLs. So if the person is able to take care of themselves, what the DSM considers to be needing, a very small amount of assistance, but they're still able to do most things, then we would call it mild. If they are not able to take care of themselves, then we would call it major. And there's so much gray area in between, because how much of it is can't due to things like physical limitations, right? Can they not put on shoes because they can no longer bend that way? Or can they not put on shoes because they get confused about which shoe and which foot, or tie, can they not tie their shoes because of arthritis? Or can they not tie their shoes because cognitively they've forgotten how to do the actual task, right? And so you have to be really careful in sort of leading through how much of it is because of cognitive issues and how much of it is because of physical limitations. The other piece of it is, if we're talking about neurocognitive disorder, sort of by definition, it is degenerative. So it gets worse over time. And so I think a lot of the thinking, or I'm speculating that some of the thinking with the DSM is that if it's going to go from mild to major anyway, how much does the distinction really matter? And we know that it does, right? So with this case, I also got a lot of different answers. I got a delirium answer from a couple folks, which makes sense if you were looking just at that point in time where she's in the ER. I did get several different neurocognitive disorder due to medical condition. Some people were more specific and said traumatic brain injury, which we would definitely want to get more information about because we don't know if the subdural hematoma is due to the fall or if it was already there. You know, lots of different answers here that subjectively, you know, we would want to get more information on, and we would want to get more questions from the doctors about.
So much of this we need those doctors.
Yeah,
It's very like medical.
absolutely. Yep. Yep. So with any neurocognitive disorders, again, we are diagnosing based on the behavior and based on the cognition. We can comment on the medical thing if we know that it's due to etiologically a medical issue. But if we don't know that for sure, then, you know, we can say due to another medical issue, but we don't actually list the diagnosis ourselves. The other one that was confusing with this is that there was lots of sort of extra information around medications because of her paranoia and this first idea that maybe it's depression with psychosis, which looks often a lot like neurocognitive disorder as well. So we rolled that out a little bit, and then lots of stuff there.
I have a question. When it comes to so many, like she's got so much medical stuff, the dizziness and all the other stuff. If this person came into your office, is it appropriate to be like, I think you need more medical intervention than psychological help? Because it's just, I mean, I'm like looking at that concern, like you need help right now.
Yeah.
What do you do?
Yeah, and that's the difference too, right? She was brought into the ER as opposed to brought into, you know, the outpatient clinic. Big difference there, right? If somebody shows up and they are actively in a delirium, then I'm absolutely going to get them to an ER. Because like we talked about last week, if somebody's actively delirious, it could be a sign that they are experiencing some sort of acute event like a stroke that could be deadly. And so any sort of delirium, you're going to get this person medical help right away. And you're not going to worry about, you know, the nuance of diagnoses. Now, let's say this is our history, right? Let's say that this is the history that the referring doctor is sending us, then, you know, that's different because then she's coming to us for therapy to help cope with these issues. Let's talk about Bridget Jones. So we know that Bridget has lupus. So if you added a diagnosis for lupus, you kind of get an easy one there. Yep. So once again, the delirium when she's brought in. Some people added a catatonia diagnosis because of the rigidity, mutism, negativism, referring to things like negative affect, anhedonia, so on and so forth, all that kind of stuff. Any other ideas here? Do you think that this is a neurocognitive disorder due to the lupus, or do we think that this is something else?
I was thinking it was due to the lupus just because of one of the tests that talked about how it had been affecting the nervous system.
Yeah, so we know that the lupus is definitely affecting her nervous system, right? We know that it's probably linked to this delirium that she experienced. But do we think she has neurocognitive disorder? We're seeing a lot of things that have to do with catatonia and other agitation. How much of that, because up here, especially when she's at the ER, this is when she's still experiencing the delirium.
I coded it as, I don't know if I'm coded it right now, but I coded it as delirium due to systemic lupus. And I don't know how to say the last word. Can I code it like that?
Yeah, absolutely. So that would probably be the most accurate information based on what we know. What gets interesting is all this other stuff down here. We don't actually know what's going on here. The ECT really throws it off. We do know that, you know, the central nervous system is involved in some way, but other than describing the catatonia, she doesn't really meet criteria for neurocognitive disorder because we're not seeing the cognitive pieces described. So we would need to ask a lot more questions. So up here, for instance, when she is screaming and needing to be physically restrained, is she needing to be physically restrained and IV fed because she's lashing out, being violent, being aggressive? Is she needing to be physically restrained and IV fed because she's catatonic and she's got that, that rigid posture? We don't know. We need a lot more information there. We don't know if it's because she's scared, because she's disoriented, because she's still delirious. We don't know if she's experiencing some sort of acute psychosis that is related to or separate from the lupus. We don't have enough information to really diagnose what the ECT and all of that is treating her for. All we know is that when she comes in, she has a delirium related to the lupus and she's exhibiting catatonic behavior, and the rest is all there, things that we need to ask more questions about. Does that make sense? Okay. Robin, what do folks think about Robin?
Let's see, I marked a major frontotemporal neurocognitive disorder
Okay.
for Robin. And let's see. Yeah, I think that was the major one that I was thinking about.
Okay. Yeah, so the frontotemporal piece we have there, we've gotten information, right? There's been testing. There's the temporal of issue. We also know that we are seeing these very, very specific behaviors and cognitions associated with the temporal lobe, the issues with faces, some of the disinhibition, the language stuff, all that kind of stuff. And then from there, you get to decide if you think it's major or mild. Did anybody think mild?
I think at first, yeah, but as it progressed, then no.
Yep. Yeah, and that makes sense, right? One thing that can be helpful, I posted a bunch of different types of testing and assessments on Canvas. Now, those are not there to tell you this is definitely mild or this is definitely major. Those are there to kind of inform you on the sorts of things that you want to look for when deciding if it's major or mild, and also the sorts of things that people are getting tested on. And all of the ones that I put there are tests that are well within your scope when you're a licensed clinician to use. So none of those are medical. They're all things that you can all use, assuming you have the proper training. But to be quite frank, the training for most of those is like, here, read a manual or go to this 3-hour training and experiment on each other. Most of it's pretty simple stuff. The other thing that those are used for, just like we use like depression batteries and other things for, is to track progress over time, right? Like if I give a client a MOCA and I see that their score changes in 6 months and then in a year, that tells me that they are experiencing deterioration, right? But all of those tests are assessments that you're able to use within the scope of your practice with the type of degree that you will all have. So let's move on and talk about all the things. So I mentioned this a little earlier. Today's material covers two very different, I guess not very different, but mostly separate topics. So during the Monday section, I don't know how much of the online folks, how much of this the online folks heard before I unmuted myself. The Monday section, there was lots and lots and lots of discussion around the second part of today's lecture. And I had actually started with that with them because that's what made the most sense at the time. But that ended up taking a good portion of the class, the whole 3 hours. And so I think today instead, because the stuff that was discussed then makes more sense with the ethics stuff we're going to discuss next week, today we are going to do the pieces on other mental disorders and medication-induced disorders. And then next week, we will talk about the things that are on slides 24 to the end. So if you're looking at your slides online, we're going to start with slide 5. Because the adjustment disorder stuff, we did talk about adjustment disorders already earlier in the term, I believe week 3. And The reason it's coming up again is because it will probably be on your exam and because we want to separate out adjustment disorders from the codes that we're going to be talking about next week. So we're going to skip that for now. I'll come back to it next week. So my two in-person people, bear with me because you can see my lecture notes up on the slide. Have fun, right? So 2 diagnoses at the end of the DSM that are, actually there's several. The 2 main ones are going to be a mental disorder due to another medical condition and other mental disorder. Both have a specified and an unspecified. So basically, there are symptoms characteristic of some kind of mental disorder due to a medical condition. And this could be something like maybe the person only has one symptom, maybe the person has symptoms from multiple things, it just doesn't fit into any of them. Typically it's 1 or 2 things, right? So the example they give you in the DSM is dissociative symptoms due to seizures. And just like with neurocognitive disorder, if you know the medical diagnosis, you're going to list the medical diagnosis first, and then you're going to say other specified mental disorder due to medical diagnosis, comma, what the symptoms are. Now with these, because you're saying it's an other specified, you need to add a specifier, whether it's dissociative symptoms, if it's depressive symptoms. Let's see, what were some of my other examples that I put up there? If it's behavioral disturbance, whatever it is, you have to add a specifier because you're calling it other specified. So let's say we have a situation, and you 2 aren't allowed to answer because you can see the typing up there, but let's say you have a situation where, okay, let's stick with the complex partial seizures and the person is having depressive symptoms. In what cases would you say other specified mental disorder due to seizures, comma, depressive type, instead of using an other specified or other unspecified depressive disorder? What do you think would be the difference?
That it meets the criteria fully, or that you have some other diagnosis.
Yeah, well, and that's the
Yeah.
kind of funky thing, right? Is that we know with the other specified depressive disorder, unspecified depressive disorder, it's because they don't meet full criteria for any of the other depressive disorders. So there's kind of this like weird Venn diagram that you can try to visualize. So if they only have the depressive disorders in the context of the seizure, the depressive symptoms rather in the context of the seizures, then you would say it's due to the seizures. So maybe it's something like, if they start to experience a lot of anhedonia and amotivation, low energy, stuff like that, and then it's a sign that they're about to have a seizure. Or maybe it only happens during their post-ictal state following the seizure, but doesn't happen the rest of the time, then I'm gonna say mental disorder due to the medical thing. Let's say it's the other way around. Let's say the fact that they have seizures makes them depressed. Then I would probably do something like an other depressive or other specified or other unspecified depressive disorder, assuming it's not due to, assuming that they don't meet full criteria for a full depressive disorder. If they did, you know, if they met full criteria for persistent depressive disorder or major depressive disorder or whatever, then you could absolutely put that there. So we really only use the other specified mental disorder when it's only 1 or 2 symptoms and it doesn't meet full criteria for anything else. A lot of weird, tricky little things there. And there's also, once again, nothing in the DSM that says, well, how many symptoms, right? This is really when we're looking at just 1 or 2 symptoms, especially something like dissociative type or something like anhedonia or amotivation, because that could be a symptom of so many other things. It doesn't really neatly fit into the other categories. Unspecified. I'm actually going to delete this because it doesn't really make sense. With unspecified, the only difference is that you don't have to put a specifier. You can, but because it is unspecified, you don't have to put a specifier and describe the symptoms. This could be something because you don't know for sure what the symptoms are. Like maybe it appears to be dissociative, but you also want to make sure they're not experiencing a delirium or something else, right? In which case you would then list them as rule outs. Or maybe they're just a little funky, right? Before or after or during a seizure, which makes sense because we know that seizures do that, or whatever the medical issue is. I've never actually seen this on anyone's chart, which doesn't mean that it doesn't happen. It's difficult to imagine circumstances unless you're in like an ER setting where you really just don't know, but you're still probably, even in those cases, you're still probably going to add a little bit more detail, right? So it's there as kind of a catch-all for, we don't know what's wrong. You know, yeah. I imagine the case studies for this week are going to have more to do with all of those extra life codes that we may or may not have time to get to today. I'm hoping we do. You guys seem less discussion-y than the other section so far, which is fine because it's Tuesday, you're tired. Yeah. That lecture will be posted if you want to see all the questions that they had. And a lot of those questions, again, are going to be covered during our ethics conversation next week.
Yeah, we can diagnose us with neurocognitive disorder due to the end of the semester.
You know, I once had an
I'm
officer
down.
who wanted me to show him how to write progress notes when I worked at the prison. And so several of us got together and wrote basically mental status exams for all of them, but we used made up things like fuckery and bullshittery and other sorts of specifiers with like prognoses like seesaw fuckery and so on and so forth. I'm sorry, Megan, you have children there, don't you? Okay. Other specified mental disorder. So this is going to be two different things. It could either be any sort of mental health symptoms that don't meet full criteria for anything else, or they have a hodgepodge of symptoms that meet criteria for multiple things, but again, don't meet full criteria for any of them, right? And then you're going to add your specifiers. It can also be used, and here's where I have seen it used pretty frequently, for conditions that just aren't in the DSM, right? And they don't feel comfortable categorizing them. So like orthorexia, for instance, some people consider that an eating disorder. Some people consider it an OCD-like issue. And so some people compromise and say, we're just going to say other specified mental disorder, comma, orthorexia, because they haven't reached a consensus yet over, which of those categories it meets. Sensory issues people will put here because is that anxiety? Is that, on the autism spectrum? It could be both. I've seen a lot of folks that are, diagnosed as autistic, and then they add an additional piece for sensory processing if that's one of the main clinical pictures, because there is no sensory processing disorder in the DSM, right? Things like internet addiction, all of that sort of stuff. The DSM mentioned sex addiction, all kinds of things that you think are a clinical issue for this person, but that don't meet full criteria for other things, and you're not sure where to put it. Yeah, sex and love addiction, which even then, there are some people who make arguments that like, okay, is this histrionic personality disorder, or is this person's behavior more reminiscent of addictive compulsive type behavior? And if you can't decide which one, right, then you can put it here, instead of saying, other personality disorder or other addictive type disorder, right? Or if you feel like it's both, all of those things. And unspecified mental disorder. This is we don't know why. It doesn't meet any of the criteria for any of the other things. And this could also be used for like, okay, this person experienced, let's say, a singular acute dissociative episode or something. And then you would say unspecified, well, that would still be a specified, I guess. But maybe you don't know if it was dissociation. Maybe it was something else. You have no idea. And you could put unspecified mental disorder, and then you could put rule out dissociative episode, rule out, substance use, rule out delirium, all of those things. Because then basically you're saying, okay, this person showed up at the ER for a mental health issue, and here are all the the options that we're considering, but you haven't decided yet. Maybe you only get 5 minutes with this person or whatever it is. But there's some reason that you're not choosing a specifier because you don't have enough information to choose a specific specifier, or choose not to for whatever reason. This can also be used for things like And I don't love using it for this, but it is sometimes necessary depending on clients' insurances. If you have a client where there's literally nothing wrong with them, and some insurances allow you to use V codes, which is what we're going to talk about the second part of class today, others do not. Yeah, and we'll talk about that more when we get to the V codes and also when we get to the ethics stuff. From there, this one's fun. Medication-induced movement disorders and other adverse effects of medication. So this is in the DSM because you are going to be working in settings where people are probably on some kind of medication, right? And there is an overlap between, say, psychiatrists, because remember the DSM-5 is used by medical doctors, by DOs, by NPs, by folks that are, surgeons and they need to look something up real quick, for, folks that are psychiatrists and are diagnosing, mental health disorders and also prescribing mental health medications. So a lot of these are in here, not because you'll necessarily be diagnosing them, but they're in here because other specialties that do things like prescribe medications are also using the DSM. And since you're working with those people, you should be aware of what they are. Yep.
Like sleep apnea.
Yeah.
Really are. Yeah.
Nope. Yeah. Right. Let's all do that. So while it is unlikely that you will be the person who says this person has akathisia due to their antipsychotic, you at least know what it looks like, what to look out for, and to be like, hey, doc, so-and-so has started experiencing this. Can you look at this for me? Because maybe you see that client more often than their prescriber does, or whatever. It's also there because part of your job is to help educate your clients, right? Like, let's do some psychoeducation and I'll teach you how your neurons work. Here's why this is happening. Or because they need to cope with it, right? Like, hey, Jimmy, you either get to decide between the demon voices in the trees or, having some shakiness. Let's help you cope and figure out, pros and cons of medication that way. So lots of things like that. So yeah, don't assume causality because that is not our job. And see what happens, right? One thing a lot of people don't realize, and a lot of this is something, it is really detrimental for some clients, some patients, because the side effects can be really, really, really rough for people. And for most people, they do resolve over time. So you will often work with people in inpatient settings where they first start on a medication, especially older first generation medications, particularly antipsychotics, where they have really terrible side effects, and those tend to go away. Same thing, like a lot of folks with antidepressants, they tend to have really, really rough side effects, and then they typically go away within about a month. If they don't, and it's affecting the person's quality of life more so than the thing it was meant to treat in the first place, then we're probably going to help them work with their doctor on finding a different one. All that kind of stuff. It's also one of those things where if you start to see these sorts of issues, you're going to want to let their doctor know right away, because it could be an indication of something else, right? It could be things like they had a different mental disorder that is now unmasked when the first mental disorder is being treated. So we talked about this a little bit with mood disorders. We think the person's depressed. We stick them on an SSNRI. They have a manic episode. Oops, turns out it was bipolar. Stuff like that. Or let's say they are having some sort of acute psychosis. They end up on an antipsychotic. And then we see, an additional issue underneath that. Maybe they are also autistic. Maybe they are also depressed. Maybe they also have adjustment disorder. Maybe there are other symptoms that we didn't know of before that are now showing up once the primary disorder has been treated. And so you also want to differentiate, like, okay, are these new symptoms actually new symptoms due to the medication, or are they new symptoms that were there all along and we didn't see because those other things were not being treated? So lots of things to think about there. We're gonna watch video. Let's see if it plays today. Ha! Whoop, maybe. Maybe. Okay, cool, whatever. Just kidding. It's fine. I had a lot of fun trying to find videos of these that weren't super sketchy because there is like an egregious number of videos out there of people just like filming their patients like 30 years ago, where clearly their patients just
Welcome
aren't
back.
aware.
In this video, we'll talk about these psychotic medications.
Okay. What's going on?
There are 4 main
What's
side
going
effects
on?
that are present in all
Where's this
antipsychotics.
coming from? It is playing there. Whatever. I don't know what's happening. It's fine.
Welcome back.
There we go.
In this video, we'll talk about the side effect of antipsychotic medications. There are 4 main side effects that are present in all antipsychotics or any other medication that blocks the action of dopamine. Starting with acute dystonia, which occurs very quickly, usually in hours or days. This is characterized by sustained muscle contraction, and this can affect any muscle in the body. The question normally mentions a patient who is taking antipsychotic medication and his eyes are closed shut and he can't open them, or his mouth is wide open and he can't close it. The treatment for dystonia is benzotropine or first-generation antihistamines, like diphenhydramine.
AKA Benadryl.
Next, we have akathisia, which takes days to develop. It's characterized by restlessness. So the patient would be unable to sit still. They would have to keep moving around or maybe keep moving their legs. It's quite the opposite of dystonia. We treat it with 3 Bs: beta blockers, benzodiazepines, and benzotropines.
So have any of you worked in hospital settings or other like residential settings with lots of folks that are, so you see people that just pace literally all day?
Well, I don't know.
Not
They get
so
very,
much.
very small. If they do
Okay.
get anything,
Okay.
like, kids.
Okay.
Yeah. So I would.
That's
never-
good.
Yeah.
That's, probably a good thing. Yeah, you will see this quite a bit. Where, and especially when folks, like the doctor in this video said, they've been on it for a couple weeks and it still hasn't really resolved. And patients will describe this to you, like, I feel like I just can't stop pacing, but they'll describe it as feeling anxious or restless, almost like a compulsion. But also then when the patient sits down, they're all over the place.
If the patient is taking antipsychotics for many weeks, they can develop Parkinsonism. Because as we know, the pathophysiology behind Parkinsonism is the lack of dopamine, and antipsychotics blocks dopamine. Presentation-wise, expect a wide range of Parkinsonism symptoms, ranging from tremors to rigidity to bradykinesia, and etc. In this case, we don't stop the antipsychotic medications, but instead we give the patient benzotropine or amantadine, which replenishes the brain reserve of dopamine. And if the patient is taking antipsychotic for many months, at least 6 months, they can develop tardive dyskinesia. It causes a repetitive contraction of any muscle of the body, characteristically lip smacking. We treat it with the monoamine oxidase inhibitor, vilbenzine, tetrabenzine, or clozapine. And here's a small quiz.
Don't know, not relevant. So some of those things are not like the others. That's fine. So basically, you can have all different issues. Most of them are going to be movement disorders, either lack of less movement or more movement, because again, that dopamine effect. We're going to get into some nitty gritty, nerdy stuff here. And the reason for that is because, again, part of your job is to teach your clients what's happening. And part of your job is to humor me because I think it's interesting. And it helps you understand a little bit more about what's actually happening in the brain with both schizophrenia, but also with these types of medications. And you are going to see them. So you're going to have a lot of folks who talk about different medications and their preferences. I've had patients straight up say like, I want Thorazine. I'm like, no, you don't though. You really don't. Like it's not good for you. It was invented, it was the first antipsychotic. It was invented in the 40s. It causes all kinds of movement disorders. But also, again, so you know what to look for if you have a client that comes in and is suddenly, showing these sorts of issues, and they're showing these different movement problems, or they're doing the tongue thing with the tardive dyskinesia, or the mouth thing with the tardive dyskinesia. You need to know, like, is my patient here, like, or is my client here because they're an antipsychotic, or are they showing this because they had some sort of stroke or other acute event and I need to get them like emergency help, right? So
in this lecture, we are going to cover pharmacology of antipsychotics. So antipsychotics are a class of drugs used primarily to treat psychotic disorders, such as schizophrenia, mania due to bipolar disorder, and severe depression.
I want to know who decides the.
Now, in order
stop
to gain
function
better
of this
understanding of mechanism of action of antipsychotic drugs, first we need to discuss the role of dopamine in the development of psychosis. So the monoamine neurotransmitter, dopamine, plays a key role in the so-called dopamine hypothesis, which argues that the unusual behavior and experiences associated with psychosis can be largely explained by changes in dopamine function in the brain. Now, dopamine has four major pathways by which it affects the brain. Number one, the mesolimbic pathway, which is thought to be hyperactive in schizophrenia and to mediate positive symptoms of psychosis, such as delusions and hallucinations.
So what else do we know happens in the mesolimbic pathway, which is essentially, like it shows here, going from the brainstem through parts of the limbic system? What else does that do? And what else might it explain in something like schizophrenia? Thoughts, ideas? You guys are under so much pressure. Anybody online? That's fair. So your limbic pathway, or your limbic system, is the part of your system that is responsible for stress responses and all sorts of other hormone-y things, right? And so it makes sense then that things like paranoia or hypervigilance and these really intense stress responses happen. It also makes sense, and we're going to get to this here in a second, that we see lowered types of stress responses that would account for things like the flat affect, all that sort of stuff. We also know
Number
that this
two,
is involved. We talked about it briefly when we were talking about substance use, where we know that parts of the dopamine pathway are under or over activated that cause, the issues that we talked about with substance use.
Cortical pathway, which is thought to be underactive in schizophrenia and thus mediate negative psychotic symptoms, such as loss of motivation and social withdrawal. Number three, the nigrostriatal pathway, which is part of the extrapyramidal nervous system and controls motor function and movement. Deficiency of dopamine in this pathway can lead to dystonia and Parkinsonian symptoms, while excess of dopamine can lead to hyperkinetic movements such as tics and dyskinesias. The last major pathway, number four, is the tubero-infundibular pathway, which controls prolactin secretion. Specifically, dopamine in this pathway inhibits prolactin release. And as a reminder, prolactin is a hormone that enables milk production and is also involved in the control of sexual desire and regulation of the immune system. Now, within those different pathways, dopamine interacts with specific receptors that mediate functional effects of dopamine. There are 5 primary types of dopamine receptors, known as D1, D2, D3, D4, and D5.
Super descriptive names. I'm going to make this bigger because I see that you're squinting.
Out of the 5, D1 and D2 receptors are found in the highest density in nearly all of the pathways involved in psychotic disorders. However, D2 receptors are the most clinically relevant because they're the main targets of antipsychotic drugs. Now, antipsychotics can be grouped into older, first-generation agents, known as typicals, and the newer, second-generation agents, known as atypicals. The first-generation typical antipsychotics all share the same main therapeutic goal, that is to block D2 receptors. Furthermore, typical antipsychotics are not selective for any of the 4 dopamine pathways, and thus will block D2 receptors in almost all areas of the brain. This has positive as well as negative consequences. So blockade of dopamine receptors in the mesolimbic pathway reduces positive symptoms, such as delusions and hallucinations, which is beneficial. However, blockade of dopamine receptors in the mesocortical pathway that is already underactive in schizophrenia may cause worsening of negative symptoms and thus lead to diminished energy, lack of motivation, restrictions in emotional and verbal expressiveness, and social disengagement. Furthermore, blockade of dopamine receptors in the nigrostriatal pathway may lead to extrapyramidal disorders, tardive dyskinesia, and Parkinson's-like symptoms, such as tremors, muscle rigidity, and difficulty in starting and stopping movements. Lastly, blockade of dopamine receptors in the tubero-infundibular pathway may cause increase in blood prolactin levels, which then may lead to galactorrhea, gynecomastia, and sexual dysfunction.
So this is something that a lot of patients worry about. It doesn't happen very often, but you will see some cisgender male patients develop like a growth or swelling in breast tissue. And you will have clients that tell you like, I don't want to take this medication because I don't want to have man boobs, right? And like, that's the words that they use. And that's a discussion that you need to have because those are the sorts of things that do affect people's view of themselves, their self-esteem, all that kind of stuff. But it is a thing that happens because of that type of antipsychotics. So.
Now, based on their affinity for D2 receptors, typical antipsychotics are often subclassified as high potency or low potency. The examples of high potency antipsychotics are haloperidol, fluphenazine, prochlorperazine, and trifluoperazine. The example of low potency antipsychotic is chlorpromazine. So generally speaking, the high potency agents produce stronger antipsychotic effect at relatively low doses. However, they also tend to cause more extrapyramidal side effects and greater increase in prolactin levels. On the other hand, the less selective low potency agents do not bind to D2 receptor as tightly as the high potency agents and generally affect a range of other receptors, including alpha-adrenergic, cholinergic, and histamine receptors.
So because we chose that particular cartoon, I did actually have a cisgender female patient once ask me if I switch my antipsychotic, will it make my breast bigger? And she wanted to switch for that reason. The answer is probably not. It is a relatively rare side effect. And when the person stops the medication, it tends to go away. So people ask all kinds of questions. Yeah, not really like earlier at the state hospital. That's the last thing you need to worry about right now, but good for you for asking, whatever.
I have a question. real quick. So I'm curious about, so it says low potency and high potency. Are you meaning like with the D, it doesn't hold as tightly to the D2 or like, does it block that receptor as strongly as the high potency one? Is that what that means?
I don't know, honestly. Couldn't tell you. Wish I knew.
Okay. I was just curious.
I will find out.
Okay. I was just curious if that's what that meant. Like it didn't block the receptor as tightly as the high potency.
So like Haldol, which is haloperidol, if we want to look at the chemical formula, show me haloperidol. Okay, that's the formula, but show me the structure. Haha. So your dopamine, this is we've got a F over here, we've got a Cl over here. So this is a very, very, very polar molecule, like super, super duper polar, like as polar as water, basically. And then let's take a look at, say, a low potency example, something like chloropazine. Chloropazine, I spelled that completely wrong. Let's do some sciencey stuff. Chlorpromazine, there we go. let's look at the actual structure here. This is also very, very polar, but it is a larger, these benzene rings over here are a much larger structure. And so it would be this nitrogen stuff happening down here with the CH3s that would be acting on the dopamine receptors. And so it looks like it is very much, like you said, a more sort of mechanical block. Over here, we see the whole molecule kind of coming in this way, the way that H2O is, right? Whereas over here, we see a whole block of benzene rings and then this singular, very, very polarized NCH2, CH3, CH3, and CH3, CH3, which is going to be its own kind of thing. And what we know about receptors is that they're super, super duper mechanical. So it's a, you know, a square peg in a round hole kind of situation. So something like this, where you look at the actual shape of the molecule, it's going to just fit into the receptors very, very differently than something like this, where the whole molecule is kind of coming in at an angle with this nitrogen, you know, carbon ring being sort of at the head of that, the way that, you know, H2O would. Does that make sense? So it really just comes down to the shape of the chemical. And so my guess would be, just based on the chemical structure, that it's going to be the way that it fits into the receptor. The other thing is that whether it's going into just D2 receptors or if it's going into, you know, the D1 through 5 receptors, and mostly just the D2 receptors, because all of those have different effects, right? We know with the first type, they sort of affect the receptors in all those different systems, whereas the others don't. They're much more specific and they only affect certain types of dopamine receptors in certain systems. Let's see what our pharmacology friend has to say. Speed pharmacology. That's a fascinating name choice, all things considered.
In a variety of side effects. For example, blockade of alpha adrenergic receptors can lead to orthostatic hypotension. Blockade of muscarinic receptors can lead to anticholinergic symptoms, such as dry mouth, blurred vision, difficulty urinating, and constipation. And blockade of H1 histamine receptors can lead to sedation and some weight gain. Now let's move on to the second generation atypical antipsychotics. In contrast to typical antipsychotics that primarily block only D2 receptors, atypical agents appear to block both D2 receptors as well as serotonin receptors subtype 2A. Because serotonin inhibits dopamine release, agents that block serotonin receptors may increase dopamine levels in brain areas that need it. Furthermore,
so what do you think that's going to do for somebody that is also dealing with depressive symptoms associated with something like schizophrenia or another psychotic disorder?
Gosh, it's gonna tank them. Like it's gonna, wouldn't it drive them more into like depression?
Well, if we are blocking serotonin reuptake, that means there's more serotonin in the system.
Oh, okay.
Yeah.
Sorry.
Yeah, no, that's okay. Yeah, it's super confusing.
No,
right?
that really helps me. That helps me learn. Thank you. Thanks for.
I mean, that's what an
going through that with me.
SSRI is too. An antidepressant is one that blocks not the receiving receptors, but rather the reuptake and receptors on the sending neuron. And so the serotonin stays in the system, is more likely to be taken up by the next neuron instead of being reabsorbed. But we do see this interplay here between serotonin and dopamine.
atypicals occupy D2 receptors transiently and dissociate quickly, allowing for relatively normal dopamine neurotransmission. This modest D2 receptor blockade in combination with serotonin receptor blockade is thought to significantly lower the incidence of extrapyramidal side effects, as well as decrease negative symptoms and improve cognition compared to typical agents.
So yeah, we're getting rid of all of those depressive-like symptoms at the same time as decreasing those positive symptoms. Because like you said, the serotonin's there, the reuptake piece is being sort of slowed down. So the serotonin can kind of short-term block the dopamine receptor. So there's more dopamine in the system where it's supposed to be, as opposed to where it's not supposed to be, and things even out a little more. Yeah, so I'm not going to make you watch the rest of this, but it is there for those of you who would like to, because those are the most relevant pieces for our purposes. And now we're going to look at actual diagnoses, things that you will see on charts and talk about with the other providers and all that stuff. Yeah, the SAMHSA, I think I shared the SAMHSA website with you before, but one of their specific curricula, illness management recovery, is a good one because it explains about, you know, at a fairly moderate difficulty level, not really simple, but not, you know, the level at which you guys are learning it. Things like, you know, why does depression happen? What does serotonin do? What does dopamine do? All that kind of stuff. And then the other piece I like about that particular curriculum, and I think I had said this before, either here in the other or in the other section, is that it is a curriculum that covers all types of diagnoses, everything from depression to bipolar to schizophrenia, kind of the main ones that you're going to see in your populations, right? And so it's really normalizing too, because it's a group format. You can do it individually. It has worksheets, all that kind of stuff. But the groups that do that, it's really cool because you'll have people that are there with something like schizophrenia and people that are there with something like persistent depressive, and they're learning about all of those different things. And it really helps to normalize for the folks that have what might otherwise be considered more serious illnesses like schizophrenia, right? Because they're learning about how their brain works and here's what's going on with my body and all that sort of stuff. So yeah. Parkinsonism. So this is not the same as the person actually having Parkinson's disease. It's more like we don't know what else to call it. So we're going to call it Parkinsonism because it looks like Parkinson's disease. We also still refer to antipsychotics in the DSM-5 as neuroleptics. So when you see neuroleptic, interchange that with antipsychotic. And this is specifically more with the first generation typical antipsychotics. So things that are happening here, note that the DSM code is the same if it's any kind of medication-induced Parkinsonism, but the ICD code is different if it's antipsychotic-induced versus other medication-induced. Any questions about any of the terms up here? One thing to note here, and you are going to see this with every single diagnosis in here, is that we're not just looking at, okay, you started this medication and now you're developing these symptoms. We're also going to look at things like cessation of other medications. So let's say you have an acute psychotic episode and they give you an antipsychotic, and in addition to that, they give you something like cogentin to kind of help ease those side effects. But then we see that once you stop the cogentin, all of a sudden those side effects start arising. Or maybe they give you something like Benadryl to help you with sleep or to help with the agitation, the anxiety, get your heart rate down, kind of just get you back to baseline. And then once the Benadryl stops, we see an uptick in these types of symptoms. So either way, that's what it's talking about when it says after reducing the dosage of a medication used to treat extrapyramidal symptoms, that's what that's referring to. Oh yeah. Yeah.
Being there, like,
yeah.
I guess,
Yeah, a lot of it is going to come down to just working with that person to figure it out. Like if you're working with somebody who is so sort of floridly psychotic that they can't keep themselves safe, they're hurting themselves, they're hurting someone else. And it's also the ethics piece of whether or not the client chooses that, right? A lot of clients will say, you know, I'd rather have, you know, the psychosis than deal with these body issues. Whereas some clients, it's the other way around. They'd rather deal with the movement related issues and having to take an extra pill like cogentin or something else to get rid of those side effects because their psychosis is so distressing the rest of the time. And it fluctuates, right? It's you get a whole mix. Neuroleptic malignant syndrome. This is extremely, extremely, extremely rare. And it's one of those things that shows up in brochures for medications that your clients are going to come to you and be like, see, this could kill me, you know? And when it does happen, it's very, very, very serious. So basically, this person has started on some kind of neuroleptic / antipsychotic, and they are having repeated high fevers, lots and lots and lots of sweating, and then much more intense rigidity. There is an excess of creatine in their blood work, and they're going to show changes in their mental status, things like delirium, they might become catatonic, all of that. And then the autonomic piece, they might become really, really, really activated, their sympathetic nervous system. And then they might become very, very suddenly unactivated and go into more of a parasympathetic type state. And it happens very, very quickly. It's usually going to correspond with the fevers, all that kind of stuff. There are some medications that are a little more intense, things like Clozaril, where the doctor will have the person take, do a weekly blood draw to monitor things like the creatine levels and whatnot to prevent this from happening. The medications where it is riskier. So it's a thing. It's relatively rare, but it is a thing. Don't ask me why it says the temperature has to be oral. I honestly don't know. And I say that because somebody asked me already. Because we have things like forehead monitors and ear thermometers and all that kind of stuff. So it's in the DSM, so it's there. So this is, again, pretty uncommon and very serious. So if this happens almost all the time, they're going to discontinue that medication because it's a serious condition and can be lethal, and try something else. So things to note. And this happens with, lots and lots of medications. There are a lot of clients who do have this belief that only psychotropic medications do this, when realistically, you could take things like Tylenol or, certain types of other prescriptions that cause repeated high fevers. Anytime you have a repeated high fever after starting a medication, you need to get that taken care of like ASAP, because that is a sign of some kind of severe reaction, whether it's an allergic reaction or if it's doing something. With this particular issue, what appears to be happening is the medication is messing up the body's ability to engage in regular thermal regulation. So the fever is kind of the symptom of that, right? So the organs are overheating, different enzymes aren't going to be able to work, all that stuff that happens when the body can't figure out what its internal temperature is. Medication-induced acute dystonia. So there wasn't really a more concise way to describe this, so I just stole it out of the DSM. This is where you will see essentially muscle cramping. Some people will describe things as mild as having an eye twitch, right? Where they just blink very, very suddenly and then it goes away, it's intermittent. But it can also be more serious things, like they get into this sort of strange posture and sort of get stuck that way. They're not quite catatonic. There's just this muscle clenching. A lot of this can also be feelings of like cramping, people will describe, but cramping in places they're not used to feeling cramping, right? Like almost everyone's experienced, say, a leg cramp, but this instead is happening in the neck or in the shoulder or, elsewhere in the trunk limbs area. And it can also be things like leg cramps, foot cramps, all that sort of stuff. Medication-induced acute akathisia. So this is, again, sort of the opposite. We saw this in the first video. This is where the person can't stop moving. It's the other way around. So this is a person who's going to be really, really fidgety. You're going to see them pacing. And again, you want to make sure it's happening because of the medication and not an unmasking of something else. Like maybe this person also has really, really serious anxiety, or there's an underlying ADHD issue. And obviously you'd want to see, do they meet the other criteria for those diagnoses? But you want to make sure, like, okay, it's not just because of the medication. Maybe the psychosis is covering up this other issue the person's also having. And that's where we would look for things like, did it happen just because of the medication? Or let's say they were on Cogentin, and it's not always prescriptions, right? Doctors will often do things like Benadryl or vitamin E or fish oil, things like that to do the exact same thing. If it's, depending on the person, if they are willing to take another prescription or not, to help reduce some of those side effects. Tardive dyskinesia, you're going to see this a lot with older clients. for a couple of reasons. The first reason is because there are risk factors associated with tardive dyskinesia that are kind of inherent with aging. Lots of stuff online about that. The other reason is because a lot of older clients, just because they've been around longer, are prescribed older antipsychotics, or they were once on older antipsychotics in really, really, really heavy doses, because maybe they were institutionalized in the 70s or 80s or early 90s and given really, really heavy doses of things like Thorazine, and now they have this problem, right? So there's kind of this two-way thing happening here. And if a person all of a sudden starts experiencing tardive dyskinesia, especially if they are older or high risk for things like stroke, you're going to want to get them evaluated right away. Most people, you'll know the difference, right? And you can ask. Most clients will tell you, like, this has been happening for a while. And this is where you see the sort of slow movements in the tongue rolling out of the mouth. If you've been around aging populations before, especially like nursing homes, that kind of thing, you've probably seen this before, where the mouth is just sort of there, it might be open, the tongue's just kind of like limp, that kind of thing. It can also be other issues around the back of the tongue. So the person could have issues with swallowing, gag reflex, all that stuff. Oopsies, typo. Other issues in the mouth and tongue. Dystonia, which we already know is a lack of movement, or akathisia, which is too much movement. Medication-induced postural tremor. So this is a fine tremor that happens when the person essentially tries to sit up straight or tries to hold any sort of position. Looks like shakiness. It's not the same as the Parkinson type tremor where it's mostly in the hands and it's kind of a slower. This is more of that like jittery, like the DSM says, what you would normally see with anxiety, caffeine, and other stimulants. Other medication-induced movement disorder. So, person develops a movement disorder. Doctor thinks it's because of the medication, and it isn't better captured by any of the others listed above, assuming they've ruled out all of the other potential issues, right? Any potential medical causes. Haven't seen this in there a lot. Usually there's something more specific, but it could show up on a chart. So there you go. Antidepressant discontinuation syndrome. This is when you will also see. There are some differences in the coding based on whether it's the first time you're seeing the client versus subsequent encounters. And that's because you get a lot of folks who show up in ERs with antidepressant discontinuation syndrome. You don't see it too often with the newer SSRIs. You do see a lot more with older SSRIs, things like Paxil, some of those sort of first generation antidepressants. It can happen with any sort of antidepressant, so the tricyclics. I listed the name brands where I know the name brands. The others I did not because I don't know them, which I guess stands to reason. You might also hear this called, especially if it's an SSRI, people, if you Google, say, serotonin syndrome, it's very similar. And it's just kind of the colloquial term, but the, correct, if we're going to be pedantic, the actual diagnosis would be antidepressant discontinuation syndrome. But just know that if people come to you and they talk to you about serotonin syndrome, they're talking about the exact same thing. It just happens to be that they were on an SSRI as opposed to a tricyclic antidepressant or an MAOI. Most people now, if they are dealing with a persistent depressive disorder or major depressive disorder, are going to be on some sort of newer SSRI, but you will occasionally get clients who, are not receptive to those, and so they end up on a stronger antidepressant, something like Paxil, Zoloft, Prozac. And some of those medications are also used if the person has additional other issues, right? Okay. So basically, don't stop your meds unless you work with your doctor to slowly stop your meds. If you run out of your meds, this will happen and it's going to feel really, really crappy, right? So people experience all kinds of things. They get nauseous, right? Because they're having withdrawal symptoms. They become really, really hypersensitive to noise and lights. We'll talk about headaches. They get lots and lots of sort of generalized anxiety. They might not be able to sleep, or they're really fatigued, or they sleep too much. The one thing that's unique about this is the brain zaps. I don't remember exactly how the DSM describes it, but most people that you talk to will describe it as feeling this sort of jolt, or this what they refer to as like the brain zaps. And it's what people like, the sort of electric thing happening. Some people describe it as feeling like a buzz or things like that. You want to make sure it's not due to something else. Is this person manic? Have they been poisoned? Are they on meth? So on and so forth. And is it part of what they were already experiencing? So if all of a sudden the person stops their SSRI and they have an uptick in anxiety, you're like, well, no shit, Sherlock, it's because you stopped your SSRI. And that's what they treat. But if it's not something that was there before, then it's probably an antidepressant discontinuation syndrome. This should go away. Almost always goes away. And oftentimes, if you are going to stop an antidepressant, the doctor will work with you to kind of slowly titrate it down. That way your system isn't getting flooded with serotonin. And they might give you something short-term to help with it. So something like Xanax that, you know, the half-life is a couple hours. So if you start to get the brain zaps or you're not able to sleep, they give you something that activates serotonin reuptake inhibition, and it goes away after a couple hours, and then you can kind of continue on your merry way titrating off the medication. A lot of doctors will also titrate down the old medication while titrating up the new medication. That way the person's levels stay somewhat consistent to help avoid that withdrawal period, especially if they're dealing with really intense symptoms, right? Because you don't want your client to get super, super, depressed because they stopped their antidepressant and they're waiting for the new one to kick in. Let's take a break. Look at my cute animals. Are they great? They're in love. 10 minutes. 5 minutes. No one cares? 7. Perfect. 7 minutes. It is 7:22. Come back at 7:29. And one of you has to remind me to start recording again. Oh, let's see. Pause record. You're the teacher now. You want to be? You should. I mean, they hired me. Oh.
We've struggled with certain.
Do I need to unpause the? That feels to be consistent during COVID and with a lot of.
Yeah, which is understandable. Yeah. Oh, we all heard about that. Probably be the big time.
Well, I'm not going to encourage anyone to do anything because that would be unethical. However, I can inform you that several of the graduate students in the MSW program are wearing rainbow cords and putting pride stickers on their hats for graduation.
I was thinking of doing that when I graduate. I didn't know that.
Because of the whole fiasco. So do with that information what you will.
I'm glad I know more about it. Because I've seen them around.
I was thinking of trying to find a rainbow dress, but I don't know where I'm going to find that. Oh wait, I'm not graduating this year. Never mind. I'm not graduating this year.
Okay.
Why did I?
Yeah.
You've got plenty of time, Monica. You can get one made.
Thank you. Kathy, well, we can go shopping. So.
Let's do it. Let's do it.
You have a year.
Well, it was really sad because there were also students who, I guess there was some kind of talk that was given by, like, the university had a speaker. That's it. What was it? Do I know? I probably don't want to know.
They would love that. Well, my parents
So they, apparently there was a speakers panel that had some really problematic content. And there was a whole fiasco where, some students didn't know that. And they were like, hey, this sounds interesting, thinking that it would be less problematic. And they sent it out to like the rest of the student body. And there was just all kinds of stuff. And I'm like, guys, leave me out of this. Like, I don't do what you're going to do. Like, this is a space where, obviously most counseling, social work, et cetera, programs are a little bit more progressive, and the classroom needs to be a place where anybody is comfortable sharing how they feel about those things, and they're not going to be, belittled or berated or whatever. And there are instructors who need to be able to put their own personal beliefs aside and make sure that that space exists. So, like, we joke a lot, we try to keep it casual, we try to keep it funny, we try to keep it light. And, regardless of whatever my political views are, that's not, it's a space where people should be able to say what they need to say. Yeah. So, oh, these animals, they're so cute. All right, let's go back here. Over here. So this next section, like I said, with the other section, the other course section ended up having lots and lots of discussion because there were a lot of questions, which is totally fine. So we can we'll probably just go through it and take questions as we go. Again, because there's so much overlap with the ethical piece. So we're going to start by going back. For those of you who are online, we're going to go back to slide 2 and look at adjustment disorders again. I'm not going to go through all the criteria since it's something we did before. But the reason this comes up in this particular section is because when we look at DSM codes that are referring to things like life circumstances, we don't want to confuse them with an adjustment disorder. So things like problems related to incarceration, problems related to military deployment, things like that. You can use them in conjunction with an adjustment disorder. Let's say the person has an adjustment disorder diagnosis because they meet the full criteria, and then you want to add one of those codes to describe what the adjustment disorder is regarding. That's fine. But they don't have to, right? A lot of these other codes are going to be for just things that are happening in that person's life that you want to capture really quickly, concisely. Most of the time, you're going to see these things show up. Let's say you do a full sort of psychosocial assessment. It's 10 pages long, and you just want to browse it really, really briefly, and you see at the end, look, okay, this person has major depressive disorder, and the next code is going to be, personal history of trauma, personal history of incarceration, or whatever those life circumstance codes are. They're not disorders. They're just there to describe what the person is going through, what they've gone through, and what you're seeing them for. Some of these are also going to be setting specific. I'll show you what I mean here in a minute. So with that in mind, we are not assuming that just because a person has any of these additional codes that they have an adjustment disorder. And that is the criteria for the adjustment disorders that we talked about a long time ago, I believe in the week 3. These are the exact same slides from week 3. And I know that because I made them. Coding. Again, with adjustment disorders, same stuff you already know. You're describing, are they depressed? Are they anxiety? Are they having behavioral disturbance? Any combination of the above, code appropriately. And so now let's look at life stuff codes. So, not disorders, right? Things the person is just going through. These can also be things that we don't have or that we don't really conceptualize as, say, disorder. So like right now, attachment styles are really, really popular all over, pop culture, media, etc. There's really not a good way of saying this person has attachment issues. It might be something that we assess for as clinicians, right? It might be that we observe different attachment styles and we might cater our treatment based on that person's attachment style. But there's no DSM diagnosis that says what your attachment style is, right? So the things that we're looking at here are going to be things like separation from caregiver, problems with primary caregiver, abuse by caregiver, things like that, that would then indicate something like an issue with attachment. First category, so the first few categories of these are fairly somber. We are going to talk about child, partner, and other types of adult abuse. First thing though is just regular stuff. Parent-child relational problem. I code this a lot because I've said this before, right? So first of all, there's the normative experience of you're a teenager and you hate your parents, okay? Your parents send you to therapy to be like, fix my kid. And I'm like, your kid's fine. They're just 16. Get over it. Get over it to the parent, not get over it to the kid, right? You know, you get all sorts of things that parents send their kids to therapy for. And a lot of times it is a communication issue, right? And so this is the code you would use for that. These are not the codes that you're going to use for things like abuse. There are different codes for that. This could also be, it could also be something more serious, right? It could be something like maybe this parent is really mean and invalidating, or they're just kind of shitty or whatever, but maybe it doesn't rise to the level of what we would clinically define as abuse. And so I would list it as a relational problem. Sibling relational problem. Okay, same kind of thing, not including abuse. Siblings don't get along. You might put these things here, you know, let's say you're doing family therapy and you have to list some kind of code for each person. You know, for the siblings, you might put that it's a sibling relational problem. Upbringing away from parents. Again, not necessarily a disorder, right? There are plenty of people who are raised by other family members or in the foster system who are just fine. Or maybe they're not, right? This is just there to describe that this is what that person is experiencing right now. So it helps paint a picture. It helps paint this sort of psychosocial picture of this person's circumstance. A child affected by parental relationship distress, same thing. So this would be something like, maybe the kid has an adjustment disorder because he has to live with one parent because of a divorce, but it could also be maybe the kid doesn't meet full criteria for an adjustment disorder and they're just needing to cope with the fact that mom and dad are fighting, or parents are getting divorced, or there's some other sort of issue, right? Parents are already divorced, they're not getting along, there's custody issues, all of those kinds of things that a kiddo might show up in your office for, just to help kind of cope with those kinds of problems, but it's not a disorder. If in addition to that, they have, say, depressive disorder, anxiety, or whatever it is, you would code that separately. This is just to describe what's happening in their life. Abuse and neglect. So these are, this was a little bit of a point of contention with your colleagues because we are looking only at clinical definitions. We are not looking at legal definitions, okay? And so if you suspect that there is physical abuse, you can code it. You should also report it, right? Because if you suspect, it's because you have a reason to suspect. And anytime you have a reason to suspect, say things like bruising, you should be reporting that. Confirmed, on the other hand, and this is kind of where the discussion comes up, is how do I know suspected versus confirmed? So the clinical definition of abuse, again, not the legal definition of abuse, but the clinical definition is non-accidental injury, regardless of whether or not the person meant to hurt the child. Sounds contradictory because you're like, well, you're separating intent from accidents. The difference is they didn't accidentally hit their kid with the belt, but they accidentally hurt them more than they meant to. Does that make sense? Or they didn't accidentally grab the kid by the arm, but the kid ended up more injured than they meant to. Or maybe they didn't, right? That's what they're really trying to point out here, is that regardless of whether or not the parent meant to hurt the child, they still did. So the intent doesn't matter. It is a non-accidental physical injury. That is kind of that is sort of the general rule, is that if it's hard enough to leave a mark, then it is in the clinical abuse category. Legally differs across county, differs across state, but that is not, you know, unless you are in the kind of job where you are doing those assessments, in which case you're going to get additional training on what is considered abuse in your jurisdiction, right? If some of you end up going and working for a prosecutor's office or a victims advocacy center, you will be having to assess those kinds of things. But for the purpose of just being a clinician and for the purpose of what the DSM-5 says, we're only looking at how they are defining abuse. So we're not looking at whether or not this person's getting charged with abuse. We're just looking at, is this person being abused clinically? Suspected versus confirmed. The reason these are coded into initial versus subsequent encounter is because of the types of settings where these things happen. So you work at a doctor's office, kiddo shows up for their regular exam, you notice bruising in the shape of a hand. That's going to be child physical abuse suspected initial encounter. Let's say they come back to be further assessed. That's going to be subsequent encounter. Let's say the mom goes, yeah, I hit him. That's going to be confirmed. You'll have parents that do that. You know, I saw you laugh, but it happens. I actually had a neighbor once who like, she's like, you're a social worker, right? And I'm like, oh, fuck, what do you want? That's never a good question to start a conversation out with. And she proceeds to pull up a photo of her child's like nude buttock to show me. And it's got like a handprint on it. And she's like, they're saying that I abused my kid. And I'm like, well, first, red flag is you're showing a near stranger a nude photo of your toddler. So like, that's going to raise the hackles. Second, and it was like one of those, I really can't tell you one thing or the other,
But are you considered a mandate?
Yep.
for that?
Oh, yeah. Oh, yeah.
Yeah.
Yep.
okay.
Sure did.
You just gave it right away?
Well, it had already been reported,
Okay.
and most reports, that's kind of the majority of reports that go through that system are going to get thrown out unless the child is an immediate risk. But you still report it. It's always your job to report. It is not.
Mhm.
Yeah.
So if she came up to you and said this is already been reported, then should you report
I would probably still report it.
it?
Yeah. Just because like, also you're showing me a naked picture of your toddler. Like, what's wrong with you? Like, I don't know you. Get out of here. Like that alone. That's weird. Yeah, it's a thing.
Like when research shows not a good form of like discipline.
Yeah. And that's kind of why it's, again, questionable. We know that because we know the research.
And I know culturally.
Yeah, all that stuff. Other circumstances related to child physical abuse. So these are basically if you are working in some kind of system where you are providing services specific to the abuse. And by that, I mean, if you are working at a victims advocacy center, if you are providing treatment for the parent or caregiver who's done the abuse, or if you're providing services, that could be things like an assessment. Let's say you end up working for DHS and you are doing the assessment with the parent, you're going to code it this way: encounter for mental health services for perpetrator, whether it's parental or non-parental. The personal history code, you will see these a lot because they are really, really, really helpful again in painting a full picture. So I do this a lot at my job as a trauma therapist. Regardless of whether or not the person meets full criteria for PTSD, if they tell me that they experienced abuse as a child, I'm going to code personal history of physical abuse as a child, because that's what they're telling me, which is the personal history part. And because it's part of, what they're there for. It is part of the full sort of whole person clinical picture. So again, not a disorder. It's just saying, here's this thing this person has told me they experienced and it's relevant. A lot of people have done a really great job in this class of, adding for almost every single case study. Does this person have a history of trauma? Does this person have a history of trauma? And while it may or may not affect whether or not you diagnose them with, say, major depressive disorder or anxiety or PTSD, whatever the actual criteria is, this is where you get to add that piece. So let's say they don't meet criteria for PTSD, but they do meet criteria for major depressive disorder, and you really strongly feel like it is related to their abuse as a child, this is the code you want to add to that. Or even if they don't, meet criteria for another diagnosis, but they're there because they just want to process some of those things, this is the code that you'll use. Child sex abuse. So again, not legal definition, clinical definition. We are considering child sex abuse to be anything, whether it is contact or non-contact, to be child sex abuse. And the reason for that is because it does affect people, even if it's non-contact, or some people like to say non-forcible. The DSM defines it as this whole broad range of things. For instance, I have a client right now who is an older adult who is really, really struggling with what to call his experience, because he doesn't feel that it rises to the level of child sex abuse. And I'm like, hey, buddy, if you're still thinking about this in your 60s and you're still having this anger toward your mother, then I would say that it's abuse, regardless of what other people might say. And the incident was multiple incidents where his mother would be taking a bath and she would call him into the room and would sort of like rise out of the tub and kind of expose herself to him in a way that made him feel like she wanted him to look at her, right? Or be seen by him in this very sort of sensual sort of way that made him really uncomfortable. And even though legally that may or may not be considered sex abuse, clinically it is, right? So all of these things. So basically any behavior, contact or none, that is intended to provide sexual gratification to the other person. Let's see. One thing to note, in the field, you might see CSA come up a lot. They don't use it in the DSM, but it is a common abbreviation in the field. And so if you see CSA, it is typically referring to child sexual abuse. Coding here, pretty much the same as your physical abuse, confirmed or suspected, first time versus multiple times that you've seen the client. These are described as encounters because oftentimes when you are working with abuse survivors, you might not be doing regular treatment. It might be in an ER setting or it might be a doctor's office. And so a lot of things are considered, I'm having an encounter or an interview or an appointment with this client, but they're not necessarily doing therapy, right? So it's kind of this discrete thing. Or maybe they are doing therapy, but this is the first time they've come in and talked to you about this type of thing. And then you would say, okay, well, during this encounter, this is what we talked about. But these are mostly here because, again, for settings like victims work, hospitals, doctors' offices, all of those places where these things tend to get reported, it's because the terminology there is you're having an encounter with the client, with the patient. So that's where things get tricky. Yeah, it's either they tell you, or, and here's where the supervision piece comes in. Sometimes parents will tell you things that they don't realize are abusive, right? And whether or not you want to call it confirmed is up to your clinical judgment. There are some people who are very, very, very conservative with their use of the word confirmed, and they won't do it unless it's actually been charged. And then there are people who won't do it unless it's been charged, convicted, all that kind of stuff. It's really up to you and your clinical judgment. If you are working in a setting where you are the person who's actually assessing if it's confirmed or not, that's very, very different. And you'll get additional training on that. You'll get the legal training on what acts constitute specific charges and all those kinds of things and what evidence looks like and all that. But for the clinical purposes, you go with what you feel is more appropriate. Yeah. Absolutely. Absolutely. Similar coding here. So again, you are the person who's on call at the jail, so you have to come in and do an assessment for the parents. You are the person who's on call at the hospital, so you have to come do an assessment with the kiddo. Or you are working with anyone and they have a past history that they share with you. That would be the personal history code. Child neglect. This one gets a little trickier. So things to keep in mind when we are talking about how we would clinically define neglect. If the parent, let's say there are things like the person is homeless, the whole family is homeless, are you going to call that neglect? There's no right or wrong answer. Yeah, we definitely need more information. Yeah. What about folks online? Any ideas?
I mean, yeah, by definition, unfortunately, yes, which sucks. It's like, I hate to say, like, kind of it's, I mean, that's the systemic issue, but yes, it is.
Yeah, again, it really depends. There's no right or wrong answer here. If you feel like this is something that is being done to the child, then absolutely. And there are differences, right? There are differences between, say, a family where the whole family is homeless versus a family where they're making that kid live in the basement, right? There is a difference between the family whose water got shut off because they don't have money versus the family who doesn't allow that child to bathe, or that child gets punished by not being allowed to bathe or whatever, you know. And so a lot of it comes down to your clinical judgment, and a lot of it comes down to what can I do to help, right? And a lot of it also comes down to the ethical issues, and this is sort of where things went with the other section, is the ethical issues around, like, okay, if I report this, what's going to happen? You are still a mandated reporter. And that's where your extra credit work comes in handy for next week. Is it duty to protect or duty to warn? Because the way that we define neglect clinically is not always the same as how we define neglect, abuse, etc., or even things like psychological abuse as a mandatory reporter in the state of Oregon. So we will be talking more about that next week. Yeah. Fun tidbit. You are allowed to still leave your baby in a basket at a fire station. That's a thing. What? That's not funny. Why am I laughing? Like a book slot, like at the library? How should they check it?
If the sensor goes off. Oh no, the sensor goes off. That was something I should have said. That's even better. After
There's like a baby alarm.
just in the wall. After a minute or two, the sensor goes off and they can open it from the other side and like, get the baby with the pen. And I guess the idea is like people are gonna leave babies here one way or the other. Let's make sure they're safe.
That's fair, yeah. Or Oregon is one of the states in which you are allowed to drop your baby off at the fire station or the military base or whatever, with the caveat that they have to be less than 1 month old and they can't have any what they refer to as obvious signs of abuse or neglect. I don't know how dropping your baby off doesn't count as neglect, but whatever, I don't make the rules. You know, let's be glad that there are options out there. I'm glad we can laugh about all the sad things. Coding, same as the others. Confirmed, suspected, initial encounter, subsequent encounter. You won't see these codes used a lot in outpatient because just the nature of what you're working on with the person. You will see these codes used a little bit more. Again, particularly the personal history. If you are in, you know, there are some programs that are very specific about diagnoses. And so like, let's say you're working in a program that is a treatment program for perpetrators or some kind of other, you know, mandated treatment program or whatever, they're going to have you code this one every single time and not worry so much about the other diagnoses because those aren't the things you're treating them for. So there's lots of wonky stuff out there. And again, we will talk about the ethics of those sorts of things next week. Psychological abuse. So this again is the clinical definition, whether you agree with it, whether it is the legal definition, whatever. But these are the sorts of things that we know have psychological effects on people. And there are things that, you know, people see a lot, right? Like you've probably seen videos of like the parent that gets mad, so they shave their kid's head and they post it on the internet. Some people think that's funny. Okay, fine, whatever. But clinically, we know that if you are publicly humiliating your child, that counts as psychological abuse. Threatening the kiddo, threatening of harm or abandonment. And this isn't like the joking kind, right? Like this isn't Liz's parents being like, oh, if you get kidnapped, they're gonna send you back because you talk too much. Like, okay, fine, it's the 90s, whatever. Or, oh, we're gonna drop you off at the military base. Like there's the joking, but then there's also the things that are said that are serious, right? This can also be the other way around. Like if you tell, they might take you away. Do you want your family to be separated? That's something that we get a lot from clients is clients will tell you, you know, the reason I never told anyone is because my mom scared me into thinking they were going to take me away and put me in an orphanage, things like that. So it's these threats of abandonment, threats of harm. It can also be things like, and again, not the same thing as punishing your child by taking away their iPad, but like, hey, I'm mad at you, so I'm going to destroy your Xbox that your dead grandma got you. Things like that, that are a little more, that are meant to intend harm. This is not referring to getting rid of things that the child cares about because they're grounded. This is like actually getting rid of the thing, destroying it, doing it in a way that is meant to cause psychological harm to the child or punish them in some way. That way. Confining. Lots of examples here. Forcing the child to inflict pain on himself or herself. So I actually have a client who disclosed to me yesterday that when she was cutting regularly and her parents found out, they got the knife that she had been cutting with and they forced her to do it in front of them. Yeah. So that would be something like coercing the child to inflict pain on himself or herself. This could be through things like food, all sorts of stuff there. Yeah.
Maybe.
Oh yeah.
They probably learned that way, like the tough love type stuff.
Yeah. Oh yeah, absolutely, right? Yeah, that was a thing. And we know now that that caused harm to people, right? It does cause psychological harm, even if it is the cultural norm. So we want to be careful with how we treat the issue because of those sort of cultural pieces, but we're still going to call it what it is because of the effects it has on the client, right? Assuming that your client is the victim, okay? Let's say that your client is the parent, right?
Yeah.
We are having this huge debate at work right now because literally a week ago, we were talking about ways that we can ask our clients about abuse that they might not think of as abuse. And one of the ones that multiple people said is like, I asked my client if they're allowed to have a door on their bedroom because parents who take away children's doors tend to be restrictive in lots of other ways. Yeah, things like privacy, whether or not the kid has their own space that feels safe for them. And this isn't like, oh, we don't have a lot of money, so we have multiple kids to a room. This is more like you're going to be punished by we're taking away your privacy, or you don't get to go and hear, because you're having a bad day, you want to walk away from the argument. You don't get to go there and lock your door, whatever, stuff like that. And that's also not the same thing as like my kid shooting heroin, so I'm removing the lock from the door, all different nuances there. But then like 3 days later, we got a new person when we were talking about parenting skills. And the example she gave, she's like, yeah, I'm all about telling parents to take their kid's phone away or their door away. And we were all like, oh, we just had this conversation. Awkward. But for some people, right, objectively, that act may or may not be considered psychological abuse. But if it is being used to humiliate or berate the child, then we would call it psychological abuse. If it's a safety thing, that's different. But if it's being used to, hurt the kid's feelings in some way, or again, humiliate them, get rid of their access to privacy, not letting them feel safe, all that stuff, then we would call that psychological abuse. Yeah.
They didn't realize how humiliating they would.
Oh yeah. Oh yeah, we got to do that. That was a thing. Let's not talk about children's dress codes. I get fired up about that. Oh yeah, definitely. So some examples of things that could be psychological abuse. Everybody knows who Harry Potter is, right? Everybody knows who Matilda is. Matilda is a great film because first of all, Roald Dahl is brilliant and he's wonderful. It's an amazing film adaptation of the book, but it also shows lots of different kinds of abuse, but mostly psychological. Other things that we don't necessarily think of, but could be harmful to the kid. I have another client who is the only adopted child in her family, and her family likes to do things like take all the other kids to Disney World and leave her at home. Yeah. Yeah, and there are some people who would be like, oh, not taking your kid to Disney World is an abuse. But in that context, I would call that psychological abuse, right? There are lots of people who don't get to go to Disneyland. That doesn't mean they're being abused, but because that particular situation, she's getting treated with this discrepancy compared to the other siblings. And she's an adult, right? So this isn't necessarily a reportable thing. But it's just the fact that it's had this effect on her, the psychological, clinical effect on her and her feelings of self-worth and all those things. And trauma therapist, that's what I'm treating her for. I'm going to call that psychological abuse. And that means I'm going to throw the code in for personal history of psychological abuse in childhood. Yep.
When I wish I could tell parents about the teacher.
you know, they don't really like it when you say things like that. So it all depends on your role.
That's why.
Well, you know, it's not so much about people listening to you more, it's more about learning how to say things differently.
You do have to say it very carefully.
Yeah, because there's probably 30 times a day where I want to grab somebody and be like, you're abusing your child. But you can't do that.
I know. It's hard.
Yeah, it's a whole thing. Spouse or partner violence, comma, physical. The DSM gives you these specific examples, and again, these are not exhaustive lists. What's the comment? There's only two of you. You can't mutter things and expect me not to ask
We
you.
just know my friend is them as boyfriend, not physical abuse. I was like, okay, psychological.
Okay. Do I need to like call in my
Well,
cousin
this is-
Tony?
I'm glad you're bringing this stuff up. Now I'm realizing when we have couples or clients.
Yeah.
How we address that stuff.
It is tricky.
Mhm.
And again, reportable or not reportable. We're talking just adults here. We're not talking disabled adults. We're not talking older adults. This is
Or knowing clients, like my friend.
Yeah.
She was in a really awful.
Yeah.
She was seeing a therapist, but there was only so much that could be done. She had. to leave.
Yep, absolutely.
It was her choice. So.
And a big reason for that is because we know that sometimes the cops showing up can cause more problems. And the presumption, and we'll talk about this again more in the ethics section next week, the presumption is that an able-bodied, able-minded adult has more options for making their own choices, which we know is not necessarily always true, but we're comparing that to, say, a child or an elderly person or a disabled person, where you are a mandatory reporter, because the presumption, and this is also problematic and sort of paternalistic, is that they can't help themselves. So there's all sorts of nuance there when it comes to reporting. But once again, we're not talking about the legal definition. We are just talking about the clinical definition. If your client is talking about these things, that's what we're going to call it. Acts for the purpose of physically protecting oneself or one's partners are excluded. So, yet again, clinically, yes, legally, maybe, maybe not. There are lots of people who are incarcerated, especially women who are incarcerated because of things they did in the context of an abusive relationship. So, how you document those things is up to you and your ethics. And what your, ethical code says. What was it?
I was going through like, yeah, you did fighting, and I got the poison. I'm like, oh shit. Like I guess, but I'm like,
Purposeful poisoning, accidental poisoning doesn't help. Okay, like grandma's a shitty cook and everybody gets food poisoning, right? Oh no, or like I had this friend that was staying with me and she really wanted to like cook us a really nice dinner as thanks, and it was like the chicken was like raw and the sauce was like, she just kept pouring wine into the sauce but didn't know to like make a roux, and then like, because she also just kept putting like flour in it, so it was like wine with like lumps of flour, and we're just like yeah, nobody got salmonella, nobody died. That would not be abuse because it was not on purpose, and I put the chicken back in the oven while she was doing something else. So yeah, like I'm not trying to, nope. So yeah, like waiting for Ashton Kutcher to pop out like, oh, you've been punked. I'm like, nope, this is serious. Spouse or partner violence coding, same stuff. Confirmed, suspected, initial, subsequent. You're probably going to see suspected more often here because, again, a lot of people don't want to share these things. They're going to deny it. They're scared to tell you because they're scared they might get hurt more. Maybe they're embarrassed. There's all kinds of reasons people are going to deny that they are experiencing some kind of abuse. And clinically, if you suspect something is going on, and that's one of the things you're trying to help that person with, add the code. Additional codes. So if you're providing victim services, if you're providing perpetrator services, treatment, or if the person shares a personal history. So again, very similar to all the others. Based on the type of service being provided, point in time. Spouse or partner violent sexual. So lots of states where this isn't a thing, doesn't matter. Clinically, this is how we define it. Note that this says within the past year, and I believe that that happens up here as well during the last year. And the reason for that is we are looking at current versus history of. How you decide that you want to code that is going to depend a lot on your judgment and if you believe that that person is still experiencing some kind of issue there, right? Has it been resolved? Has it not been resolved? All those things. I have a client right now where my client is actually the perpetrator, and we were trying to figure out how to have that conversation with him because he's also seeing, the couple is seeing one of my colleagues for couples work. It's a heterosexual partner, the female partner is seeing someone else for individual work. And my client came in, this is the ED guy. This is the guy that started his first day with, I have erectile dysfunction. I'm like, cool, buddy. But then at our most recent meeting, he having a bad morning, why are you having a bad morning? Got in a fight with so-and-so. Okay, well, what happened? And she apparently was upset because she felt that he had pressured her into having sex and he didn't understand why she felt that way. And so, complicated situation. How do we code that, right? How do you decide what to put there? We didn't continue that conversation that day because it's only like the third time I've met with this guy.
You're saying like talk about how do you address that, or like
Yeah, well, yeah, and the answer to that is, well, we're all going to do a consultation with the couples therapist and her individual therapist and decide how are we going to address this. Am I going to address it with him? Is it going to be addressed in couples? If they bring it up as an issue, is it going to be addressed with her? You know, who's going to do it and how, right? That's where your clinical consultations become really, really handy. And I am not doing sex offender treatment with him, so I'm not going to put encounter for mental health services for perpetrator because that's was one of many things that person talked about that day. However, it's in there as it was added to her chart for suspected, right? Because that's what her individual counselor chose to add. So lots of icky gray areas there with how to code these things. The other thing that comes up with that person is my client has a history of being incarcerated multiple times, never for a sex offense. And this is my own sort of ethical line. If he had a history of sexual offending, that would be, I would treat that very, very differently than, okay, this person is clearly not understanding, as opposed to, yeah, it was a whole weird, wonky thing that we spent about 2 hours trying to kind of sort through as a team. But that is something we would consider in addition to things like physical rape. Those are things we would consider to be sexual violence clinically. Well, yeah, absolutely. Yep, talk about it with the team, talk about it with your supervisor, so on and so forth. Spouse or partner neglect. You might see this in elderly populations, populations where one person is disabled, populations where there's some sort of language barrier, all of those sorts of things. You might also see this in situations that appear a little more gray. So culture-specific situations. Let's say you have a married couple where one person is entirely financially dependent on the other partner. And then you have to see how is this affecting, and say that partner is withholding money and saying, you know, you're going to have an allowance as if they're a child or whatever, right? If for that person that feels normal and that feels fine, that's one thing. But if for that person they feel like they're being punished in some way, or they feel like it's affecting them emotionally in some way, that's something else. And so you kind of have to grapple with your own ethics around whether or not you would consider that to be spouse or partner neglect. There are lots of cultures, even in mainstream culture, where that is considered totally normal. There are certain, even Christian sects, where that is considered totally normal. And so you kind of have to grapple and figure out whether or not clinically you believe that that is what this person is experiencing. With other issues, let's say, you know, the more obvious things, like the person's disabled and the partner isn't changing them, feeding them, whatever. and it's their job, right? As opposed to professional caregiver, which is a whole other issue. Then yeah, we're going to say that that's very obviously spouse or partner neglect, and you're also going to report that as a, if the person's disabled, that's a mandatory report. So coding for that, same as all the others. And once again here, same as the others. Spouse or partner abuse, psychological. There is a separate section on other adult abuse that is non-spouse. So like a stranger stalking somebody is going to be a different code than being stalked by domestic partner, which we will get to. But these are all the things here for spouse or partner abuse, psychological. Is this reportable? Yeah. Yeah, it's an icky feeling because technically, if this is an able-bodied, able-minded adult, you are not allowed to break your confidentiality to report something like this, even spouse physical or spouse sexual abuse. That's not the same as if I believe this person is going to go hurt someone else. And that's where your whole duty to warn versus duty to protect thing comes in that you're all going to learn about next week. Coding, suspected, confirmed, initial, subsequent, so on and so forth. Coding for providing victim services, reporting personal history, and providing perpetrator services. It is nice that these codes exist, again, because you might have people who come in to cope with these types of issues who don't meet full criteria for PTSD. And so this gives you a way to say, I'm providing this very necessary service, even if they don't have a disorder, right? That also helps to depathologize these very real experiences that people have. You know, we're not saying that you are disordered because you are a survivor, right? We're saying that I'm providing you a service because you're a survivor, and we can kind of conceptualize it a little bit differently. Adult abuse by a non-spouse or non-partner. So all the same stuff, but not their partner. Roommates, two people in some kind of facility, all that stuff. Stranger. So these again are codes that you're going to use a lot if you're working in any kind of victims advocacy center or victim services center. The DSM doesn't list them all out separately, physical, sexual, or psychological, because I think they figure that you've already read the definitions. Same definitions, same examples. And again, not exhaustive lists, right? There are lots of things that are psychological abuse or sexual abuse or physical abuse that aren't on this list. These are just examples that the DSM gives you. Codes. All the same things. Is it physical, sexual, or psychological? Is it first encounter, subsequent encounters, or personal history, victim services versus perpetrator services, treatments, so on and so forth. You're not expected to memorize these, as with any codes. All right, let's lighten it up a little bit. Educational and occupational problems. So we are going to try to separate this conceptually from things like learning disabilities, because this can be a result of a learning disability, in which case you would code it in addition to learning disability if you feel like it needs to. I mean, it's already kind of part of the definition of learning disabilities because we know that the clinical criteria for learning disabilities includes having problems at school or work or whatever. But this could also be things like kids not getting along with teacher, kids getting into trouble at school, things that people might send someone to treatment for that, you know, they don't actually meet criteria for a whole, you know, a disorder of any kind, but they're having this issue. School counselors use these codes a lot for obvious reasons. It could also be somebody's illiterate, right? Low-level literacy, things like that. I'm going to list that as an educational occupational problem because it tells me something about that client. It tells me, it kind of, you know, adds to that whole client picture. Depending on the setting you work in, you might see folks that are low-level literacy or illiterate but don't have any disabilities, and it's because of poverty, issues with education, all that sort of stuff. I've had clients at the state hospital that don't know how to read or write and don't exist on paper because they were born, you know, wherever, and they just came into existence, never went to school, whatever. And then they end up in the system as like a middle-aged adult because something happened, right? And so it does still happen. The reason this is listed as its own thing too is because we want to separate out, say, educational issues from things like intellectual functioning. You can have a person who's a complete and total genius, but if they were never taught how to read, they were never taught how to read. And so we're going to code that differently, right? We're not going to say this person has an intellectual disability. We're not going to say that this person has a learning disability. Maybe they do, but if they don't, then we're going to call it an educational problem. Occupational problems. The DSM has a specific code for issues related to military deployments. A lot of that is because the Department of Veterans Affairs has become really prominent in the APA scene over the last 20 years or so, because they didn't historically have the best mental health care. And so they are much more involved in mental health care now. And part of it is because there are issues inherent to deployment that you don't see with other types of occupations. Some people might argue that, right? There are folks who would argue like, well, you know, I'm a trucker, I'm gone all the time. That's similar, kind of, but not really. However you want to conceptualize it, but you do code it separately. Other problems related to employment. So whole range of things here. The person is coming in because they're having trouble coping with the job change. They are having trouble with their boss. It's a hostile work environment. None of those things are mental disorders, right? But they're coming because that's what they're having trouble with. And again, if, let's say, they meet full criteria for an adjustment disorder because of a recent job loss, then yes, you could code the adjustment disorder. But the reason these are here is because we want to be really, really careful not to pathologize normal human experiences, right? There are things that are stressful for most people, doesn't mean they meet full criteria for an adjustment disorder. Housing and economic problems. If your client's homeless, list that they're homeless. If they have inadequate housing, which the DSM defines as a structure that is not, they're in a house, but it is not a good one. Lack of plumbing, loss of electricity, all that sort of stuff. Homeless is living outside or in any kind of structure that is not fit for human habitation, which should be a tent, or the DSM lists a cave, which I think is just a fascinating, like, where did that come from? That's really oddly specific. Like, why a cave? Like, who lives in a cave? As opposed to under a bridge or like normal homelessness type places, whatever. If you find someone living in a cave, they are technically homeless, according to the DSM. Discord with neighbor, lodger, or landlord. Again, could be anything from I'm stressed out because I hate my landlord, so I'm coming to talk to a therapist about it, or it could be like there's a new, we've seen Netflix special called Worst Roommate Ever that is about like squatters and things like that and the psychological stress that puts on the person. All of those things. Problem related to living in a residential institution. So pretty self-explanatory. This is a person that lives in a group home, hospital, jail, whatever, and they are having issues that are related to that. A whole range of things. It could be coping with loss of freedom. Could be coping with loss of not just freedom like incarceration, but also freedom like I have a curfew now and I'm an adult and I don't like that. Or I have to share a kitchen now and I don't like that. Or I used to live with my family and now I have to live in a group home. All of those kinds of things. Or I don't get along with my cellie, right? All of those kinds of issues. I was also told once when I worked with the person not to list this because they're like, well, everyone doesn't get along with their cellie. I'm like, that's not true. I know lots of people who get along with their cellie really, really, really well. And maybe it's a problem for you, you know, Mr. Priya person, but it's not a problem for them. They're very happy. Housing and economic problems continued. So again, not disorders, but things that you would note because you're doing a full assessment of your client and you want to be able to code for these specific issues that are adding to your client's distress. Insufficient social insurance or welfare support. That was one that came up yesterday. So that is referring to people that aren't getting the support that they need for whatever reason. So let's say they've applied, they've been denied, or they've applied, they're getting some support, but it's not enough, which is most definitely often the case, especially in a place like Oregon where we have high costs, right? So Social Security numbers are based on the federal poverty level, which is egregiously outdated, and a person's work history. The most I've ever seen anybody get from Social Security who had a really extensive work history was about $1,400 a month. And that was money that they had paid in, right? That is not enough money to live on in a place like Oregon. There might be other places where it is, here it is not. So that I would say is insufficient social insurance or welfare support. It's also a thing that if you are getting Social Security, or let's say you trying to get onto OHP or SNAP or any of those other programs, if you have more than $2,000 in your bank account or in any other sort of financial asset, they will say no, because you have too much money. Right? Yeah, it's really, really stupid. So for any of you that are on OHP, you better get that $2,000 out and stick it in somewhere else. Well, that's the thing. A lot of homeless people will carry their money in cash for that reason, but then it gets stolen or something like that happens. Oregon does have special savings accounts for those types of situations. Let's say you are low income, but you're trying to save for your kid to go to college, but you don't want your benefits to get cut off because you got $2,000. The other issue that comes up a lot is you're homeless and you want to get an apartment. So you need to save first month's, last month's deposit. That's more than $2,000, right? And so there are all sorts of issues like that. Or let's say the person's getting SNAP. For most single people, it's about $170. A lot of single people can live off of that. If you're, you know, not getting steak and lobster all the time, fine, whatever. Maybe every now and then. But for families, they get a little bit more per family member, but it's often not enough for the family to live off of. And so we would code, you know, insufficient social insurance, welfare support. Unspecified housing or economic problem. This could be any issue that person is having, but there isn't already a code for, or any issue that that person is having. And with all unspecified codes, you don't want to put the reason or don't know the reason. This sounds stupid, but your client that comes in and is convinced that their house is haunted and they don't feel safe, that's going to be an unspecified housing or economic problem. And I'm going to list it under, you know, they have some odd beliefs, but this person in particular that I have in mind doesn't meet full criteria for any of the psychotic disorders or any of the personality disorders about odd beliefs and none of those things. And so I'm going to call this a housing problem because it is causing this person to not stay at their house. Other problems related to social environments. Phase of life problem. This is just, again, normative experiences. Person's retiring, person is becoming a parent, person is becoming an empty nester, person is aging, all of these just sort of life developmental things that somebody might be coming to counseling for. Problems related to living alone. If this person is really, really struggling with issues of loneliness, isolation, maybe they are a young adult and they've never been on their own before. Maybe they're exiting the foster system and they don't know how to live on their own. They're losing all their resources. Maybe their partner has left them and they now live alone and they don't feel safe, comfortable. All of those sorts of things. Acculturation difficulty. What's that?
I feel like I would be into that because like moving from
Yeah.
California here.
Oh, yeah. Yeah, absolutely. And again, totally normative thing to be stressed about, normal thing that a person might get counseling about. And as always, the reason adjustment disorder is included in this section on the syllabus is because we want to differentiate whether or not this person has a clinical diagnosis of something like adjustment disorder or a trauma, anxiety, whatever related type diagnosis versus is this just a thing that they're dealing with? It's a normal experience, or maybe both. Acculturation difficulty, pretty self-explanatory here, happening frequently depending on the area where you live. I have a client right now who is Latina, and she is really, really struggling with the dynamic of being a second generation. You know, things like having to be the interpreter for her parents, things like her parents constantly encouraging her to marry a white guy so that her kids have lighter skin. All of these sort of complex issues around acculturation. None of those are disorders, but that is what she is struggling with, and so that is the code that is on there. Social exclusion or rejection, exactly what it sounds like. You could get snarky with this one and be like, you know, this poor incel, whatever, blah, blah, blah. But the reality is this is also people who are experiencing things like bullying. I use this code a lot with a lot of my adolescents because that's what they are experiencing subjectively. And that's why they are getting sent to counseling. There's nothing wrong with them. They don't have any kind of diagnosable issue, but they are getting bullied and they need help figuring out what to do with that. Maybe you're teaching them social skills or some other kind of way to deal with whatever that issue is. Maybe they got broken up with. And so that might be considered rejection. And they don't, again, they're not meeting full criteria for another diagnosable issue. Targets of perceived adverse discrimination or persecution. The DSM is very, very clear in the way they add the word perceived, because you don't get to decide if that person's actually being discriminated against or not. If they are coming to you because they feel like they're getting discriminated against, it is your job to help them with that, help them cope with it. If you have strong feelings about whether or not they're getting discriminated against, that's where it's important to do some sort of cultural consultation, maybe send them to someone else. Or it could also be, maybe we're looking at other issues. Either way though, if that is what the person tells you they're experiencing, that is the way that you code it. Because when you're doing any kind of counseling, you are helping the person with their reality, whether or not you agree with it. The word perceived was added in the DSM-5 because it became such a point of argument among the DSM committee and the APA and the powers that be, whether or not it mattered if the person was actually experiencing discrimination. And the consensus is it doesn't matter. That's not your job. Your job is to treat them. And then unspecified problem related to social environments. Anything that isn't included up here. Problems related to crime or interaction with the legal system. So you're seeing a client who has recently been victimized. Cool, we're gonna add that there. Conviction in civil or criminal proceedings without imprisonment. This is the thing that you might add. Let's say your client's gotten a DUI and that's what they are there to get help with. Or maybe, you know, they're getting sued and they are stressed about that. Imprisonment or other incarceration. I don't know what other incarceration means, but whatever. Cool. Problems related to release from prison. Problems related to other legal circumstances. So that could be things like there are issues with custody. Maybe they're in the middle of a lawsuit where they're the ones not having it against them. For instance, I am working with a family that witnessed a pretty brutal murder. and they are now suing for wrongful death. And a big piece of the work with them is helping them. First, there's the trauma piece, because it's a couple and one of them has very, very clear PTSD, the other does not. And so that's a whole thing. But then there's also this issue of the lawsuits and helping them decide as a couple what to do with it, how to cope with it, help them, kind of mediate their disagreements about it, hook them up with the correct services, all that sort of stuff. Other health service encounters. If you go to your doctor and talk to them about birth control, you are going to see a sex counseling code show up on your chart, because that is what you did during your visit. It's really just that simple. And this isn't the same thing as sex therapy or treatment for a sexual dysfunction. This is just, hey, we talked about this. Or this is an issue that person's dealing with. And it could be things just like attitudes, or they are trying to figure out issues around sexuality. Maybe they are youth and they are going through some sort of normative sexual experience, but that's what they need help coping with, not a disorder. But they want to talk about it. They want to learn, what to do with certain circumstances, all that kind of stuff. Other counseling or consultation. You see this a lot for just regular consultations. Maybe if you are in some kind of practice where you do a consultation before the person actually becomes your client. And so you're not doing a full assessment yet. You're just setting up your initial appointment, but maybe you talk to them on the phone for a half an hour and, basically see if they'd be a good fit, whatever. Really?
We're at the same.
Yeah.
He said they
Some people do, some people don't.
Yeah.
A lot of clients are like, I just want to come in and talk to you face to face. I don't want to have a 20-minute phone call. Some clinicians do this for free. Others, and will still document it sort of stringently, right? For whatever reason. Because let's say that person calls you for a consultation and then they go out and murder somebody. And you didn't document it because they're not your client. Unlikely depending on the population that you work with. And, it's also there for things like, let's say you work for the states and you work in their nicotine cessation program, which is one of Oregon's biggest state provided health counseling programs, or any kind of like public health counseling type thing. That code is there for that. It's 8:30. Okay, cool. Additional problems. Religious or spiritual problem. If you're doing some kind of pastoral counseling, that's what you would code. This could also be a person who is just struggling with things like that. Maybe they have experienced something where they are questioning their faith, or they just really want to process through their beliefs. You see this a lot, especially with young people who are trying to figure out their beliefs. You can also use this for things like religious trauma, if you don't know how else to code that. So a whole range of things. Problems related to unwanted pregnancy, problems related to multiparity. I like these in particular because it really just shows the bias in the DSM committee, because it doesn't, account for the nuance, right? It says unwanted pregnancy, but like I have a client right now who has a wanted pregnancy, but it was an unplanned pregnancy. And so that's what she's working on. I'm like, well, I'm not going to code it as unwanted because that's not accurate. Yeah. So that's a thing. Multiparity is things like twins, triplets, etc.
Yeah, that would be a hard one.
Unexpected bonus babies. Yep, it's a thing. Discord with social service provider, also a great one. I hate my therapist. Pretty much, yeah. And you don't have to code it, right? These are also things that could be genuine. Like, let's say that they are having some sort of problem. Okay, like my PO is picking on me, blah, blah, blah. All right, let's figure that out. Stuff. I've never actually seen that code looked. Yeah, or if it's something, so like I have a client who is in mandated treatment for a sex offense. But the person's offense was a really, really long, and to be frank, they don't need sex offender treatment. It was a non-contact offense that happened like 20 years ago. They were using at the time. But because of the states where they committed the offense, they have very different laws than here. And so even where in Oregon, what this person did would be considered an SO level 1, which is like the least, like not predatory at all. They're from Arizona. You know how Arizona is with their law enforcement. And this person has children and they're not allowed to like go pick them up at school. It's a whole thing. What they did was wrong. Don't get me wrong. I'm not downplaying what they did. But the whole thing is that now they're having this discord with their PO from Arizona. And it's just a whole drama.
Yeah.
And so like, I'm going to code it that way because that's what I'm helping you cope with. And we're going to leave it at that. Right. And this isn't the same thing as like this person's engaging in staff splitting. This is more like, I'm genuinely seeing a problem here. Let's figure that out. Yeah. Victim of terrorism or torture, pretty self-explanatory. Exposure to war, disaster, other hostilities. Other problem, in which case you would specify it, and then unspecified problem, you don't specify it. Other circumstances of personal history. If you have a client who has ever self-harmed, you put a personal history of self-harm. Because again, it just adds to that whole clinical picture. Other personal history of psychological trauma. We don't see this one as often as we should, because again, there are lots of people that have experienced trauma, but they don't meet full criteria for PTSD. And so every time you guys have asked that question with the case studies, do they have some kind of trauma that is contributing to this disorder or that disorder? If the answer is yes, then you can add this code. That's really what it's there for, because you're trying to form that whole person picture. If they've been deployed, other personal risk factors, problem related to lifestyle. This could mean whatever you want it to mean. What does that actually mean? What do you think? Yeah. Yeah. Yeah, there's a lot of bias stuff there, right? Particularly with the word lifestyle. I've never seen this particular code used except in cases where there does appear to be a lot of bias, because often the things that might be considered lifestyle are better captured by, say, psychosocial issues or economic issues, those other codes we've already gone over. And if you feel like there is a lifestyle issue that the client is telling you is contributing to their presenting problem, then that might be where you add it. This could also be things like, okay, unspecified eating disorder, and then I'm going to add the code problem related to lifestyle. You know, yeah, or this could also be things like,
Or alcohol, like even if it's not considered alcohol abuse.
yeah. Yep.
That's what came to mind. Like, I guess if someone's saying.
Yeah, if they don't meet full criteria for
But if
use
someone goes to
disorder.
get a drink at night,
Yeah, although in that case, you know, maybe like, let's say they go after work every day, they go to happy hour with their coworkers,
Yeah.
and it's affecting their family life. Maybe they don't meet full criteria. You know, they are not using too much, they're not using in excess, they're having one drink a day. We know how the DSM defines excess. It's not affecting, it's having adverse effects on their family, but that's the only criteria they meet. In that case, I would probably still put an unspecified substance use issue, but it really depends again on how you want to conceptualize it and how culturally you would conceptualize it. The one time I saw this come up was a client that was a sex worker, and the previous provider had put problem related to lifestyle. And in this case, I changed it and put problem like occupational problem. The client's issues were about work in general, and that yes, they were occupation specific issues, but for this client, that was a job. And it was just a job. And so I'm not going to call that lifestyle, right? Because it's an occupational issue. Yeah. Additional personal history. So adult antisocial behavior. that don't meet criteria for antisocial personality disorder. This one is also a thing that I love how they say professional thieves. I don't know what a professional thief is. I don't know what that means. Like the thief and the cobbler, you know, like the movie from back in the day or something. This one is kind of a point of contention because if you have a client who is engaging in this kind of behavior for survival, as opposed to what we would typically call antisocial. And that's why there's that separation with the personality disorder. Same thing with child or adolescent antisocial behavior. This one you might see a little bit more because maybe the parent brings their kid in and they're like, they stole something from the store. And you're like, okay, that's what we're going to talk about today. And then maybe we're going to deal with other stuff later. It was a one-time thing, whatever. Whether or not you want to call that antisocial or not is up to you and how you conceptualize antisocial. As opposed to intermittent explosive disorder, conduct disorder. So isolated acts. Dealers in illegal substances. Okay. How you conceptualize things like this compared to, say, an economic problem. And that's where you really want to figure out how the client sees it, right? I'm stealing because fuck those people, I don't care, or I'm stealing because I'm hungry, right? It's the difference between like, I'm stealing electronics because I think they're cool and I want to put them in my car versus I'm stealing electronics because I need to sell them so I can pay my rent. One of those I would probably list as an economic problem. The other I would list as antisocial. Just depends on, but again, your personal ethics and how you want to conceptualize what your client is dealing with. Other problems related to medical and other healthcare. This is a pertinent one, considering what we were talking about at the beginning of class. Accessibility for any kind of healthcare here. This is things like client really needs a surgery, but they're on a wait list and they have to cope with that. Clients waiting for a transplant and they are getting counseling in the meantime. Client is trying to get an abortion and they can't. Regardless of how you feel about the client's issue, this is the problem. It is lack of access or lack of availability, and so that is what you code. And then same thing, other helping agencies. So maybe you have a client who you are seeing for something very, very specific that your agency does, but you know that they need a different type of treatment and you can't find it anywhere. We have a client that we just had to unfortunately stop seeing because their Medicaid rejected the claim and they can't afford to private pay, which is a really crappy feeling. So I'm going to call that inaccessibility because this person isn't able to get the services that they need. Yeah. Do you have OHP? Yeah. Okay. What county? Yeah. They're usually fairly generous in Multnomah County. So if you are having any specific issues that you would like to ask about, shoot me an email and maybe I can help with you. All right, non-adherence to medical treatments. This one is also really contentious. So let's go through these one by one. One by one. Includes medical and mental health disorders. This could be things like the person stops taking their meds. This could be things like the person doesn't understand that they're sick. This could be things like an elderly person who has some kind of issue and they're like, fuck it, let me die, which happens. This could be things like a person who has neurocognitive disorders and they forget their meds. This could be issues around cultural beliefs. I'm snarky, and so if I get somebody who comes in and tells me they refuse to vaccinate their child, even though their doctor told them to, I code this because I'm an asshole. Personal ethics, whatever you want to do with that. Overweight or obesity. This one is really interesting because being overweight or obesity is not a behavior or a medical treatment. It is a state of being or a description. So why it is in this section, nobody really knows other than, well, and that's the thing. You might describe a person as overweight when you are describing their general description. Or you might describe them as obese because you're the doctor and you've decided that their BMI meets that description. Yeah, totally. Yeah. The part here that's weird is that it is in the non-adherence to medical treatments section, which doesn't make sense because again, it is not a behavior. There are different behaviors that could lead to weight gain, but being big in of itself is not non-adherence to medical treatments. That's just not like being in a larger body does not mean that you are not adhering to medical treatment. And so we will see what that looks like in the next DSM. It's an interesting one. There are lots and lots and lots of, if you read the original committee notes, they basically just threw their hands up because nobody could decide where else to put it.
Nice.
Whatever. Yeah. I'm here to inform you what is in the DSM because that's my job. I don't believe it qualifies as not adherence to medical treatment because again, it is a state of being and not a behavior, but you know, what do I know? Thanks. Lots of
Just
details.
like reading the information.
Malingering. Good old malingering. I've had a couple people bring up potential malingering for some of the case studies so far. So here is how the DSM actually defines it. And we're going to talk a little bit about this and the difference between malingering and fictitious disorder. So malingering is when we know that there's some sort of external incentive, okay? So cadet bone spurs, that kind of stuff. They do point out that malingering can represent an adaptive behavior. They use an extreme example of feigning illness while captive of enemy during wartime. It can also be really silly stuff, like your 7-year-old didn't want to be at school anymore because he was nervous, so he goes to the nurse, says, my belly hurts, can I go home, right? That's malingering. There's a clear external motivator, so on and so forth. I don't want to take my exam, so I'm going to call Liz and tell her that I'm dying. And then I post a bunch of pictures at the bar. Liz doesn't know that because she's not a weirdo, but then someone else tells her this has happened. First of all, don't snitch on your peers because I don't want to be a part of it. Okay, I don't want to know. I don't care. Don't tell me. Whatever. If your doctor says you're sick, I'm going to believe your doctor. If you see your classmates doing things they're not supposed to, please don't involve me. Because that was not a fun situation for me to have to tease out. Yeah. Yeah, undergrads. So, malingering. Oh, yeah. I'm like, you guys keep your drama, like, get out of here. Yeah, I'm like, I don't want to know. I don't care if you saw them at the bar. Like, that is not my problem. What are you doing at the bar? I don't give a fuck. Like, I don't care. Leave me out of it. Right? Or like report it to the people you're supposed to report it to, but don't be like, oh, so-and-so's at the bar, but they said they were sick, so they have to take their test later. And I'm like, now what do I do? Thanks, asshole. You're both assholes. Get out of here. Go home. Right, go whine about it on TikTok or something, where kids do these days. Malingering. So, how do you know the difference between malingering and fictitious disorder? Any ideas? Hey, look, it's on the next slide. You want to roll out all of these. Yep. You're going to want to roll out somatic symptom related disorders because that person truly feels the symptoms they're reporting, right? When we went over those. Conversion disorder, same thing. They truly feel what they are telling you. Factitious disorder, maybe they are feigning or inducing symptoms, but we don't know that there's an external motivation. There appears to be no external motivation. Same thing, fictitious disorder by proxy, all that stuff. Note that there is no malingering by proxy. So little Johnny gets in trouble, he's going to jail, mommy calls and says it's because of XYZ. Not a thing. Mommy starts poisoning Johnny so that he doesn't go to jail. That's going to be fictitious by proxy. Even though there's an external motivator, I mean, actually, that's going to be adult abuse. I take that back. That's probably not going to be fictitious by proxy. That's going to be you've got some, some stuff there. So the other thing with malingering, be very, 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 very careful if you code for malingering, because once it is on there, that client is going to have a lot of trouble with other diagnoses. So let's say they get a malingering code and then they genuinely do develop some kind of issue later on, related or unrelated, they're not going to be taken as seriously. It can also have really, really serious adverse consequences. So like in my role at the state hospital, when we are assessing people for things like guilty acceptance sanity, even though you can technically put malingering based on their clinical presentation, the best practice is that we don't do it. We do testing first. So a licensed psychologist comes in and does all sorts of specific testing batteries that look for things like effort testing and malingering, because the stakes in those situations are so high. Wandering associated with a mental disorder. So common in neurocognitive disorders, like we talked about, it can also be other issues. I love how they call it wandering here. If let's say you've got a kiddo with conduct disorder and they like to run away, we code that as wandering. Let's say you've got somebody who's just a little confused and they wander around because they're lost, but it's due to something like maybe they have an IDDD and they get lost easily, and wandering is a big enough part of their clinical picture that you want to add the code so that you know that this person needs help with that particular issue. My dog likes to take herself for walks. I've recently discovered that there's a sneak out spot in the fence. I discovered this because when I came home over the weekend, she was sitting on the porch looking very, very sad that no one would let her back into the house that she snuck out of because she's a genius.
Very sad.
Moron. I'm very grateful that she brought herself home.
It's really cute. It's scary. Yeah.
Ooh, good job. It's the saddest face. Yeah. My cats go wandering. That's socially acceptable, not so much for the dog, right? If I was diagnosing my dog, I would put wandering associated with the mental disorder. The mental disorder would probably be some kind of personality issue. She also likes to not eat when I'm not around because she's sad. So it could be dependent, it could be borderline, I don't know. She's a rescue, she's got issues. Last but not least, borderline intellectual functioning. This is basically a person who, this is such a weird diagnosis. They are not IDDD, they don't meet the cutoff, they're in that in-between range, they are low average, a standard deviation or 2. So this is the person where maybe they are doing just fine with whatever they are doing in life, but it's going to affect the type of treatment that you do with them. We have a fellow at it's actually the fellow that had the whole, I don't understand why she thinks I pressured her thing. And we were trying to figure out one of the reasons we were trying to figure out how to approach it with him is, so he doesn't have any learning disabilities, but the word we decided to use was simple. He's very, very concrete, has never had formal testing, so we can't technically diagnose borderline intellectual functioning, but that would be the type of thing that you would look for. And because of that, you know, we're not going to do some of that more abstract type of work, right? Like this guy would do amazing with like something like DBT when it comes to the other relationship issues, but he does not have the capability to form that level of abstraction. So I ordered the modified DBT for IDDD folks, and I'm going to pick and choose things from both curriculum based on how he presents in terms of his ability to abstract. But yeah, when you see this on a chart, it basically means the person has lower than average intelligence, but they are not intellectually disabled. And it's a nice way of saying that they are not the sharpest current in the box. And so you need to be aware of that because it's going to affect the sort of treatment that you do with them. Let's see. You also want to make sure, just like we do with IDDD, that when the person's getting tested, that there aren't other issues that interfere with it. And so this has come up a lot, and we've had to raise this problem a lot, where I've seen clinicians who will slap on this code, even though the person hasn't gotten tested, or the person got tested, but there's another issue that interfered with the testing. So they are floridly psychotic at the time, or they have a neurocognitive disorder, or they have a learning disability, something else that interferes with the ability to actually do valid intelligence testing. You don't see it very often because most of the time the person doing the testing is a licensed psychologist and that's what they're trained to do, but you might see it in other settings where people don't know about the testing piece or they don't think about the testing piece, and maybe they have good intentions, but not a great diagnosis unless you've actually had that person tested. Does that make sense? Yeah. That is it for our additional codes, right on time. Look at that. We did all the things today. Good job. Thanks for listening to me talk for 3 hours. Email me questions. There's a kitty. Who's the kitty? Lindsay's kitty. What's the kitty's name?
Maui.
Like Meowie? That's amazing.
Well, we have a chunky one over here that's Loki. And so we needed another god of mischief, so we went with Maui.
Excellent. Excellent. Okay. Very good. Anybody have any questions about all the additional V codes?
Not per se about the V codes unless they apply to this week's case studies. Are those all adjustment disorder things or eclectic type things, or I haven't read through them yet?
So what is great about V codes is you can throw them in wherever you see fit.
All right.
And that is all I will tell you.
It's a V code fest. All right.
Yep. I mean, again, a lot of folks did an amazing job with asking questions about things that would end up being V codes with the earlier case studies, you know, things that are part of the clinical picture, but aren't necessarily part of the diagnosis. So go for it. Yeah. Well, it is 8:59. I'm going to let you all go. And then don't forget, if you want bonus points, send me an email telling me the difference between duty to protect, duty to warn, and what your job is in that context as a mandatory reporter. And like I said, if you have an A+, whatever, you're welcome to look it up anyway, but I'm probably not going to give you extra points for it because, you know, yeah. Extra work for you that is unnecessary because you can't get an A++ on your report card, and extra work for me that I don't want to do. Full disclosure. Don't be that person. And no, I'm not going to ask all of you to share in front of each other who doesn't have an A, because that's also a dick move, and I'm not going to be that person. But we will be having a discussion about duty to warn versus duty to protect and all the other ethical type stuff in your book. Bye guys, have a lovely evening. Oh no, there's stuff in the chat and I missed it. Oh, they're all saying thank you. You're welcome. Never tell people are being sarcastic when they thank me.